Pelvic organ prolapse for fitness professionals. Hello, my name is Nidhi. I am a doctor of physical therapy. I am an orthopedic clinical specialist and a women's health clinical specialist through American Physical Therapy Association. Um, my practice is in Mamaroneck, New York, which is slightly north of New York City. I have been a PT since 2009. Majority of my practice is pelvic health. I started as an orthopedic PT. I did back pain, neck pain, all that kind of thing. And then eventually, as I got into pelvic health, I think that orthopedic background is what I still operate with, and it's very helpful. My social media handle is pelvicharmony.pt, which is probably where you found me. I'm gonna see if I can myself here. Okay. So, pelvic organ prolapse, the lived experience. I read this article in 2022, which is when I launched this course for the first time. Um, and this article really became the reason I created this course. I had been feeling this way for a long time because I see pelvic organ prolapse patients all the time. But this article really kind of pushed me to do something about it because the lived experience of women with pelvic organ prolapse is awful. These women are scared, they are heartbroken, they literally feel like their organs are going to fall out of their body any minute. And I have personally seen that in my clinic, and I'm sure you have seen that in your clinics or in your practices in gym. They are so disheartened, so scared. So, whatever that we have been doing for these women, protecting them, caring for them, surgery for them, is clearly not doing enough because majority of women with pelvic organ prolapse are really, really scared and really, really hurt. Um, these are the statements from that study. No, no exercise, like I literally do nothing, which is desperate, but it's hard to find an exercise that is prolapse friendly. I'd say I think about something related to my prolapse 3 to 4 times an hour. I was very conscious of not being able to lift and not being able to care for him, the baby, in the same way that I would have wanted to because I wasn't able to run around and just lift him up on things, lift him up for a hug and stuff like that. And I hear this all the time. I hear this all the time. So, our approach towards pelvic organ prolapse for so long, prolapse is not new, prolapse has been documented for decades now. Um, our approach towards prolapse is not working because these women aren't able to function. So I really wanted to create something that will empower other PTs, empower trainers, yoga teachers, and everyone, including women, to feel empowered and sort of take away that fear that just clouds over everything that we talk about prolapse. Okay. This is the outline. I'm going to keep moving this window so it's not blocking. Let's see, it's here. Okay. So outline is we have 4 sections to this webinar. We are going to start with the basics, anatomy, physiology, like where are we, get the lay of the land, what is prolapse, what happens, what are the symptoms, etc. We're going to go into second section, which is probably the most important section of this webinar, and we're going to talk about core and pressure systems. We're going to talk about what is intra-abdominal pressure, what basically is happening in prolapse, what can we do to change that. Then in third section, we'll go into factors affecting POP, alignment, breath, foot, hip, spine, hypermobility, diet. And then fourth section is really just all practical stuff about how to modify exercises, what exercises to do, how to change things. And we're going to get into more specifics of running, high impact activities. Okay. Housekeeping, general questions can go in the chat. Anytime question comes to your mind, put it in the chat. We will get to those questions in the break time. If you have a conceptual question, especially in that second section, intra-abdominal pressure, please ask that question because it's important that you understand that to build up. So if it's a burning conceptual question, just unmute yourself and ask that question. There are two breaks, 10 minutes each. We'll see where we take them, usually between the sections. We definitely will be over 4 hours. I'll finish in 4 hours, but I'll be here for final Q&A afterwards. I'll also be here during the break time to answer your questions. Don't exit meeting room if you're going in and out. Sometimes Zoom gives me like a notification to let people in. So just mute yourself and mute the program, go somewhere, you can come back and it'll be on. All right, a note about evidence. So I have read a lot of evidence about prolapse. I really try to keep up on all the research that's coming out. But the reality is that there is not a whole lot of research about prolapse in terms of exercises. A lot of research that we have for prolapse is just relating to Kegels. What kinds of Kegels? How many times do we do them? What do we do them? The quality of them. And Kegels do work. There's good evidence to say that Kegels will improve symptoms. But we know, we have seen from that article in 2022, Kegels aren't doing enough for people. Kegels aren't making enough difference in people's lives. So I cannot teach a course here and talk all about Kegels because in reality, we see that Kegels just do not do enough and sometimes do harm. So I would love to be evidence-based, but evidence is literally just for Kegels. So what I have done here, which is what a lot of clinicians are doing in pelvic health, is we're pulling research from incontinence, leaking research, lower back pain, hip pain, core function. We're pulling research from different regions nearby pelvis, and we're trying to apply that logic or those findings to pelvis. So a lot of research that I'm quoting here isn't in women who have pelvic organ prolapse. That's true. But it is nearby research. That's my disclaimer. And it is something that I personally use in my clinic. Generally, I'll mention if something is my personal experience and my clinical reality, not really the evidence. I'll generally mention that. But there is a whole list, 5 pages of all the references from this course at the end of the PowerPoint, and you'll get those slides. Just- Okay. All right, so let's go. Let's get into it. Anatomy and physiology. So let's get a lay of the land here. This is the pelvis we're talking about. Okay. This is the bone on the right here, bone on the left. Okay. Pubic bone in the front, sacrum in the back, tailbone in the back. Inside, we look right behind the pubic bone is bladder, where the pee collects. Right behind that is uterus, and behind that is rectum. When we take these organs out, everything that's red inside is pelvic floor. So pelvic floor is not one muscle, it's a group of muscles that sit inside the pelvis. They form from front of the pelvis to back, side to side, and it's like a hammock. There are small muscles of the pelvic floor at the opening, and of course, there are deep muscles inside the pelvis, and all of those muscles together make the pelvic floor. Organs inside the pelvis sit high up. They should sit like way up in the pelvis. So when we look down at the perineum, when we look down at the opening of the vagina, we should see a clear opening. We should see labia majora, we should see labia minora, outer lips, inner lips. And when we pull the lips apart, we should see a clear opening. Okay. Sometimes when these organs descend down from their place, we will pull the labia majora apart and we will see a little tissue sticking out. Okay, it looks like a little tissue. Sometimes it looks like a little bulge, little blueberry. Some people will say it feels like it's a tampon stuck inside. That might be a pelvic organ prolapse. Different organs can prolapse. Most common is bladder. Second is rectum. Uterus can prolapse. There's also enterocoel where the intestines prolapse and other things, urethral prolapse. But our most common ones are bladder, uterus, and rectum. Okay, I already talked about the pelvic floor deep muscles. The deep muscles of the pelvic floor, which are the deepest inside the pelvis, they are the meat and potatoes of the pelvic floor. They basically squeeze and lift. They lift the organs up, they lift the bladder up, they lift the uterus up. The second layer of muscles kind of wrap around the urethra and they work as sphincters to close the urethral opening to help you pee, hold your pee. And then there are superficial muscles of the pelvic floor that mostly will help in arousal and orgasm, and they sit at the opening. So now let's talk about organ support. I think this is the main thing that people are confused about. Because when we look at this model, and this model where we have organs sitting inside, if I take the organs out, here's the pelvic floor. And that kind of creates a doubt or a faulty presentation that creates a misconception that pelvic floor is holding the organs. Okay, it makes us feel like, oh, organs are here, pelvic floor is here, so of course pelvic floor is the basket that's carrying the organs. Now that's not true. There has been a lot of research that proves that there are three levels of support for the organs. So if the organs are here, up here, there are big ligaments. Think of ligaments as ropes that attach the organs to the side of the pelvis. Okay, so the first level of support, the top level of support for the organs, come from ligaments that suspend the organs from the bony pelvis. So there will be two ligaments here that call uterosacral ligaments. There are round ligaments, there are broad ligaments, there's ligament for the bladder, there's ligament for the rectum. So all of the organs are attached to the pelvis through big, thick ligaments. That's the upper level of support. Then, and you can see those ligaments in here, they're labeled. Then what this picture doesn't show is the middle level of support, which is the middle third of vagina and has a lot of fascia. Think of fascia as like thick fishnet, very thick leathery fishnet. And that fishnet sits at the middle level of these organs and kind of fill up all that space that was left by the ligaments. So pelvic fascia is the second level of support, and it gives a lot of support to these organs to stay in place. And then we have pelvic floor at the bottom, which forms like a sling or a basket underneath the organs. Okay, so if you see the first picture, you see the ligaments and you see the fascia. You don't see the fascia, but ligaments, and fascia would be here. And second picture shows the muscles. Now, if you put the two pictures together, you will understand that organs stay in place due to a lot of things: ligaments, fascia, muscles. Okay. The primary reason for pelvic organ prolapse is that these ligaments get loose or stretched or injured. Okay, so it can get loose or stretched in birth, it can get loose or stretched in menopause, they can get loose and stretched because of conditions, hypermobility conditions like Ehlers-Danlos syndrome. So we can have very strong pelvic floor, very nicely or even tight pelvic floor, and still have organs falling out or coming out of the vagina. That's an important thing to understand, because pelvic organ prolapse sometimes becomes synonymous with weak pelvic floor, and that's a fault, because pelvic organ prolapse, if anything, should be synonymous with stretched ligaments and stretched fascia. Pelvic floor may or may not be weak. It often is weak because it's pregnancy related, but it is not inherently correlated. I have seen plenty of people with very weak pelvic floor and no prolapse, and many, many people with very tight or very strong, not even tight, very strong, healthy pelvic floor and have prolapse. So we have to get this out of our head that it's all the fault of weak muscles. It's not. Okay, so due to pregnancy, due to menopause, due to other things, and we'll talk about all those things, ligaments get looser, they get stretched, and the organs start to descend down. And then when they start to descend down, now they sit a lot more in the pelvic floor. Remember, I said the organs sit high up, there's a ligaments, fascia, and the pelvic floor is at the bottom. Pelvic floor, in fact, at rest in a anatomy without pelvic organ prolapse does not take much weight. Pelvic floor does not take a whole lot of weight. When we cough or sneeze or jump, yes, it takes weight. But sitting there resting, pelvic floor does not take the weight of the organs. It's not lifting the organs. What's keeping the organs up is ligaments and fascia. So pelvic floor is like a buffer at the bottom. When we do something, it's going to catch the organs. So what happens in pelvic organ prolapse is really this dry dock. So if you had a boat docked to the sides of a dock and there's water underneath. Now imagine if the rope got weaker, if the rope got thinner for whatever reason, the boat will start to sink. And now how much water you have underneath matters. Okay, so what we are seeing here is that because these ligaments are the primary drivers of organs being lower, what do these ligaments attach to? They attach to the front of the pelvis. They attach the back of the pelvis. They attach to side of the pelvis. And what attaches to those pelvic bones? Your abdominals, your glutes, your hip muscles. So can we change the mechanics of these muscles that attach to our bony pelvis so that the bony pelvis alignment and mechanics changes and help the ligaments do better to support the organs? Okay, and this is where we start to see that we can do a lot more than just muscular strengthening at the pelvic floor to change prolapse, because prolapse isn't a problem of weak pelvic floor. It's a problem of stretched ligament that attach to the bony pelvis, which attaches to a lot many other things. All right. So before we go on, I want to talk about synergist muscles to pelvic floor, since we kind of talked about pelvic floor already. There are three muscles of pelvic floor of our body that generally help pelvic floor. Okay, and this comes from the research on incontinence and lower back pain. It doesn't necessarily come from the research on prolapse, but we know that obturator internus, which is a muscle that extends the hip and abducts the hip. So it's an external rotator of the extended hip. So when we bring the leg back and we externally rotate it, or the abductor of a flexed hip. So when we make a figure four position, when we make a figure four position. So obturator internus has been shown because it attaches to the ligament where the pelvic floor attaches, ATLA. When obturator internus contracts, it kind of takes the pelvic floor with it. Okay, people who have pelvic floor tightness, pelvic pain, we often find a lot of tightness at the obturator internus as well. So obturator internus, which is an external abductor of a flexed hip and external rotator of an extended hip, can help in pelvic floor contraction. So when the pelvic floor is having a hard time, or we need to give pelvic floor a little bit more help, we can recruit this muscle. We'll talk about this later. We have also seen that adductors, especially Dr. Magnus, has fascial connections as they insert into the pelvis, and adduction movement can help increase the contraction of the pelvic floor. And we know the deepest part of our abdominals, transverse abdominis, has sort of a neurological connection to pelvic floor. Whenever I ask my patients to do a pelvic floor contraction, they often co-contract a transverse abdominis, or when we say a transverse abdominis contraction will bring the pelvic floor contraction. And for those who don't know where a transverse abdominis is, if we take all the six-pack muscles away and we take the obliques away, the deepest muscle of our core looks like a corset. And that corset muscle is called transverse abdominis. So transverse abdominis, adductors, which is the inner thigh muscles, and obturator internus are three muscles that are synergist to pelvic floor. So when we need the if pelvic floor is weak and we need to get a better contraction of the pelvic floor in a movement, we can use these muscles. If the pelvic floor is not weak, but we need it to do a little bit better to compensate in a movement, we can use these muscles. If somebody is having a lot of symptoms of pain and tightness and discomfort in a movement with pelvic organ prolapse, we should probably look at obturator internus and adductors. They might be too tight, they might be fighting too much, they may not be turning off. Okay, and we'll talk about all that as we go on in the presentation. Grades. So there are four grades of prolapse. Grade 1 is more than 1 centimeter above the level of hymen. Stage 2 is within 1 centimeter of hymen above or below. Stage 3, 1 to 2 centimeters below the hymen. And stage 4, more than 2 centimeter below the hymen. Majority of people that we are looking at and treating and working with in gyms and clinics are either a stage 2 or a low stage 3. So they're stage 2 most of the time. They see a small bulge coming out of the vagina, or they don't see it, and then they run or walk, they see something. Most women with stage 1 don't really feel anything because that part of the vaginal canal doesn't have sensory nerves, that doesn't have sensory output. Stage 3, when it's 1 to 2 centimeters below the hymen, women will feel it more persistently, and it's harder for them to kind of create a contraction, pull it back in. And stage 4 generally is pretty persistent, like there's something coming out and they are much more symptomatic. At stage 4, we are definitely looking at some kind of support device like a pessary. Stage 3, a lot of times we're looking at some kind of support device. Stage 1 and 2, we can generally manage with exercises and physical therapy. Okay, symptoms. Symptoms are important because a lot of women with stage 2 have a lot of symptoms. And a lot of women with stage 2 have no symptoms. I have seen this so many times in my clinic. There is a bulge coming out of a woman's vagina. I'll do an exam, I'll find it, and I'll ask her if she has any symptoms, and she doesn't even know that it's there. Okay. And a lot of women who have a grade 1 or a very low grade 2 prolapse, and they feel a lot. So it's very important to understand that symptoms do not very often correlate with the prolapse unless it's a grade 3 or 4. Grade 4 will always correlate. Grade 3 will many times correlate, but grade 2, when the prolapse is within 1 centimeters inside or outside the introitus or the opening, some women will feel a lot of symptoms and some women feel no symptoms. So what causes that? And there are a few different explanations, but one of the biggest explanation that I have found in my clinical practice is how worried is this woman about her prolapse? So you heard in that study earlier, I said some women think about their prolapse 2 to 3 times in an hour. So if somebody that is that worried about their prolapse, they will squeeze their pelvic floor and kind of keep it clenched, and that clenching will make the prolapse more symptomatic. It will make the prolapse more noticeable to them. And this is how it works. So hold on one second. So imagine this is prolapse, right? This is the organ, and this is the vaginal canal, and this is where the organ sits. So that it's like sitting low, but it's not coming out of the vagina. Now, when we do a pelvic floor contraction, we can narrow the vaginal canal, we can make it smaller. So when we narrow the vaginal canal and we make it smaller, we can generally lift the organ up. But now watch what happens. If somebody contracts the pelvic floor and keeps contracting and never lets go, now the vaginal canal is narrower around the organ. So even though the organ is not lower, the woman will feel worse because she's squeezing constantly around this organ. So women who have tight pelvic floor or kind of a panicky or very nervous pelvic floor tend to have more symptoms with the same degree of prolapse. And there's evidence for this now. So women who have tight pelvic floor with the grade 2 will be more symptomatic than women who have relaxed pelvic floor, even though both of them have the same degree of prolapse. And that's very important to understand, especially if you're a trainer and you don't actually do a physical exam, that somebody says, oh my God, I feel a lot of prolapse. That does not mean the exercise did it. That does not mean that she's getting worse. That does not mean, it can mean many things, but it doesn't necessarily have to mean that her prolapse is lower, okay, or her prolapse is getting worse. Main symptoms is vaginal bulging sensation. Women will say something's, I feel like something's coming out, something's falling out, dragging sensation, pelvis feels heavy, feel like there's a tampon stuck inside my vagina, pelvic groin pulling sensations, deep, dull pelvic pain, especially in the sacrum, the back of the pelvis, feeling of stuck poop, and post-void dribble. So, feeling of stuck poop and post-void dribble is important. As the prolapse gets worse, so this is the organ, this is the bladder, this is the urethra where the pee comes out of. As the organ gets more and more prolapse and it kind of sinks down into the vagina, the urethra will develop a kink. It will develop like a fold here. And from that fold, the bladder will not be able to empty completely. So a higher grade prolapse, a high 2, 3, or 4 grade prolapse, women will often report that I feel like there is more pee and it's not coming out, or I pee and then I stand up and then I pee again. I feel like, oh, there was more pee. So this post-void dribble where they pee, stand up and then leak, or pee, stand up and feel like I have to pee some more, is often a sign of pelvic organ prolapse for the bladder. Post feeling of stuck poop for women is I feel like there is poop, it's right there, but it's not coming out. Or I feel like there's poop, but it's in the wrong place. Some women will say, I feel like I need to push into my vagina to get my poop out. So when the rectum is prolapsing into when the rectum is prolapsing into the vagina, it forms a little fold here. And in that fold, the poop gets stuck. So sometimes women will put their hand in their vagina and kind of push this fold back so the poop comes out. So inability to empty these organs because now they're not in their place and the tubes from which the pee and the poop comes out is kinked or folded so the poop and pee cannot flow out easily is one of the classic signs of a high grade prolapse. Feeling of bulging, feeling of heaviness, like something's falling, something dragging, is a classic symptom of a second degree prolapse. Pain actually is not a classic symptom of prolapse. It sometimes happens, but there is possibility of a high grade prolapse with no pain whatsoever. Okay. For research, prolapse of 0.5 centimeter outside is what is consistently reported by women. Anything below that may or may not be symptomatic. Okay. It's also important that prolapse to know that prolapse symptoms are not consistent. They're not constant. A lot of women will they wake up in the morning, organs are back because the gravity has been helping all night. They wake up in the morning, they have no symptoms, right? So somebody might have feeling of heaviness and bulge only after running, or they may only have symptoms after they have been carrying their kids for a while, or they may only have symptoms when they jump or run or exercise. So we have to kind of ask them, if you're screening a person who you might think has prolapse or anyone who is postpartum, you have to ask them, do you feel bulging sensation at any time of the day, especially after exercising or carrying babies? Okay. Now, it's also important to know grade 1 prolapse is so common that a lot of researchers say that it probably is a normal change in our physiology. It's very unlikely for anyone to have 2 or 3 kids and not have their organs move even a little bit, right? So sometimes we're saying that now we all develop wrinkles, right? Is that pathology? Is that a disease? No, it's aging, right? So it's possible that some degree of moving down of organs, especially in grade 1, when the women doesn't have any symptoms and you don't, it's not coming out, it may be somewhat normal, right? Now, I'm not saying don't manage it, don't talk about it, but try not to worry women about it. You have a grade 1 prolapse, especially in postpartum for like 3 months, 6 months, the chances of that prolapse going away is very high. And us mentioning and pathologizing it, telling that, this is grade one, grade two, grade three, grade four, makes the woman worried and keeps her from doing things that she would have done. Give all the education that you should give, but know that grade one uh, may be a variant of normal. All right, leaking with prolapse. We already talked about this. The urethra, as it comes out of the bladder here, so if my finger was urethra, when the bladder sinks from its place because it's kind of falling into the vaginal canal, there is a kink that develops between this bladder and the urethra. So now when you cough or sneeze or jump, you do not leak because this kink gets deeper. So bladder gets pushed and the kink gets deeper, so the pee cannot come out. So leaking can be a sign of pelvic organ prolapse, but leaking is not a very consistent sign of pelvic organ prolapse. So just because somebody is not leaking doesn't mean she doesn't have prolapse. Okay. In fact, we see that as the prolapse progresses, as the woman develops more prolapse, feels more bulge, more heaviness, she actually leaks less. Okay, so most women with grade 3 or grade 4 prolapse don't leak because they can't even empty their bladder because of that kink. So there is no way to leak. The bladder keeps filling and that kink keeps them from leaking. So in this ultrasound, you can see on the left-hand side picture, you can see that nice bladder and then the straight urethra coming down from it. And you see on the other picture, the bladder is kind of elongated and sort of falling into the vaginal canal. And I have circled that point where the bladder neck meets the urethra and it's kinked. And as she coughs or jumps or the bladder fills, that bladder will come down more and more, and that kink will get deeper to the point that it can close urethra. Okay. How common is it? Very common. Prolapse is very, very common. Approximately 50% of women are living with pelvic organ prolapse. That is half of the population. And a much higher percentage in 40 plus or even higher in postmenopausal. So you train someone with prolapse whether you know it or not. More symptoms do not mean harm. And we have to really approach prolapse with a biopsychosocial perspective. And we should approach all healthcare with that perspective, but especially prolapse, because it really messes with your head. It really messes with women's head when they know that there is an organ coming out. And first of all, it's not the organ, it's the vaginal canal that's kind of bulging. The organ is behind it. In the case of uterus, actual organ is coming down. But we have to tell them that your organ's not going to fall out. It's okay. Because that worry creates tension in the pelvic floor, creates contraction of pelvic floor, contraction of ab, contraction of inner thigh. They want to keep everything in because they're scared that things are going to fall out. And in an effort to keep everything in, they tighten up everything and squeeze the organ even more and create more pathology over a period of time. So it's very, very, very important. I keep saying this in this whole webinar to tell these women their organs are not falling out. More symptoms do not mean more harm. And if anything, teach them how, I mean, not how, just look down, pull your labia apart, look at the prolapse. And if you're very, very worried that your prolapse is getting worse because you feel more heaviness, go lie down, do this again. Is the prolapse really worse? 99 out of 100 times, it's not worse. It just feels worse. Okay. And it's important to understand that prolapse doesn't develop, right? It quickly. It's not a thing that, oh, you just did one run and now you have prolapse. Prolapse has been coming on this whole time. It often develops over months in pregnancy, or over years in hypermobility conditions, or over years in menopause years. So it doesn't develop from a run or a hike or a weekend trip you did. The run or the hike or the weekend trip may be the trigger that makes you feel it. But the prolapse had been happening. So we have to educate women that prolapse is not a quick thing that happens. It takes time for the body to do that. And that means 10 sit-ups or 20 jumping jacks or you picking up your grandkids because you wanted to isn't going to cause prolapse, isn't going to make your um, prolapse fall down, make it from grade 2 to 3, because women really think that's the case. Why does prolapse happen? So there are many, many risk factors for prolapse, and some of them are modifiable risk factors that we can change, and that's what I'm going to discuss first because that's important. That's something we can actually do something about, and then we'll talk about the risk factors that we cannot change. So BMI more than 25 has been linked to prolapse, especially in perimenopausal and menopausal women. Asthma or chronic cough. So when we cough, we push the diaphragm and the organs down consistently, and doing that over a period of time does increase the chances of organ prolapse because pelvic floor is constantly getting that strain of the cough. We see that in kids and women, kids and people with cystic fibrosis who have this chronic constant cough. Even at young ages, they will end up developing urinary incontinence because that constant strain in the pelvic floor is a lot. Chronic cough is also one of the things that women will become symptomatic with. So prolapse was happening. They didn't feel it or felt it sometimes, and then they got sick. And they coughed for 3 months or coughed for 3 weeks constantly, and they think, oh my God, my cough caused my prolapse. Prolapse was there, cough made it symptomatic. Frequent heart stool or constipation is one of the most consistent modifiable risk factors. And it's crazy because pregnant women are so constipated and they're told, oh, well, constipation, it happens to you. They get hemorrhoids, they get fissures, they get all these problems in pregnancy. And I know there's hormonal components. We have to take iron that causes constipation. But in pregnancy, really try to educate your clients and patients about avoiding constipation because their pelvic floor is already stretched, their ligaments are already stretched, there's hormones, there's baby, all the things are already there ripe for making the organs and making the ligaments and the pelvic floor weak. Now we add constipation to it and they're sitting there and bearing down or straining their pelvic floor for long periods of time. So I will often say, do whatever you need to do. Take Miralax. If diet and all the other things don't work, talk to your doctor, take something to manage constipation. They should not be constipated chronically. And of course, all the other women we should educate. Family history of POP has been strong risk factor. So if somebody has a mother or a sister with POP, they're 2 to 3 more times more likely to develop prolapse, especially uterine prolapse. Signs of connective tissue disorders. So if they have a lot of varicose veins and hemorrhoids and hernia, that means their tissue, the collagen in their tissue is kind of weak, is kind of not, it's the type that has more flexible fibers than the sturdy fibers. So they're more likely to develop prolapse. Heavy occupational work. So people who are lifting heavy weights, this is not lifting for exercise. We're talking about, people who are lifting luggage at the airports or people who cashiers who have to lift a lot of groceries, people who are lifting without getting a break or lifting beyond the capacity of what their body can handle. Vaginal delivery is a strong risk factor. That does not mean all vaginal deliveries cause prolapse, but we do see that people with cesarean will have less incidence of prolapse. Use of forceps during vaginal delivery is a strong risk factor. So if you have someone, especially if you're a PT, who had a forceps delivery, even if you don't see any symptoms, you should definitely screen them for prolapse. If you're a trainer, somebody has a forceps or a vacuum delivery, tell them to go to a PT and get their pelvic floor assessed. Because again, at 2 months postpartum, they may not feel anything. But as the baby gets heavier, they get back to their exercise, they start running, the prolapse may become more and more prominent. So we have to educate women about that. Levator avulsion, which is the tear of the levator pelvic floor muscles from the pubic bone, will increase the chances of prolapse. and shape of the pelvis. There has been some research about certain shapes of pelvis predisposing to the prolapse. Again, we can educate about forceps, we can educate about vaginal delivery, we can educate about occupational work. There's not a lot of things we can do. Of course, birth prep and all that stuff, but sometimes sometimes forceps delivery happens. Occupational work is not in a lot of control. So the three very modifiable risk factors, obesity, cough, and constipation, I want you to talk about them all the time and educate people on the other factors. And also, this may be a starting point for a conversation about an elective cesarean. So, if somebody has a very strong family history of organ prolapse and they also do heavy occupational work, and they also have asthma or constipation, then it's okay to have a conversation with them and tell them all about risk factors that they can choose an elective cesarean because vaginal delivery will increase their chances of developing prolapse. So it's a nuanced conversation, especially if you're a physical therapist, to have with the patients. Don't scare them, but present the information. I don't think it's bad that if women choose to have a cesarean and elective cesarean because they have a very strong family history of prolapse or very strong family history of Ehlers-Danlos syndrome hypermobility. It's just empowering people. Don't tell them, don't scare them, but talk to them with nuance is not a bad thing. Okay. So now let's get to how does prolapse management work? So now we have talked about why prolapse happens, right? Prolapse is a mismanagement or unequal pressures in our body. That's the basic premise of prolapse. Organs stay in place as soon as I stand up, as soon as I am against gravity. My organs, all my intestines and stomach and lungs, everything's gonna fall down. Gravity, right? So everything's gonna fall down as soon as we stand up. That's gonna happen because that's we live on Earth, there's gravity, and that is called downward pressure. From the bottom, those ligaments, those fascia, those pelvic floor muscles will create upward pressure. They will create a gentle contraction and upward pressure to match that downward pressure. Okay. And ideally, that upward pressure and downward pressure will match each other out and organs will not move. Now, in prolapse, because these ligaments have gotten weaker and the fascia has gotten weaker and maybe pelvic floor has gotten weaker, the downward force on the organ is more than the upward force on the organs. So now the organs move down. So a mismanagement of pressure or mismatch of pressure. Now let's talk about, wait, where does that go? Where's that? Sorry, should have had that. Oh, okay. So mismanage of pressure. So what should we do? We should decrease the downward pressure. That makes sense, right? We should decrease the downward pressure. We should decrease the downward pressure. How do we decrease the downward pressure? We're going to talk about how can we change the breath patterns. We should stop bearing down. Constipation, cough, we talked about that. Manage obesity so the weight of the body is less. Stop sucking the belly in. So we're going to talk about this a little bit more later, but this is your pelvic floor. This is your diaphragm where you breathe from, and these are your abs. When you have very squeezy abs, people suck their belly in. See what happens to the pelvic floor. When I suck my belly in, when my jeans are too tight, or when I wear a waist trainer and I tighten it to get a narrow waist, where does that pressure go? That pressure goes into the pelvic floor. So sucking belly in, waist trainers, very, very restrictive clothes that doesn't let you breathe properly will cause downward pressure. Okay, so we have to decrease the downward pressure. That's the first thing we have to do. Then we have to increase the upward force, which means pelvic floor strength. So that doesn't mean pelvic floor is weak. It can be weak. If it's weak, we strengthen it. But even if the pelvic floor is of a good strength, now because the ligaments and fascia is weak, we may need to get more bulk in the pelvic floor so it can compensate for some of those weaknesses and the other structures, because we can't change the ligament, we can't change the fascia. Well, maybe we can, we'll talk about that, but we can definitely strengthen a muscle, add more muscle fibers, add more bulk to it so we can compensate. Hip strength, we talked about that, how the hip muscles will reinforce the pelvic floor contraction. So hip strength will help. Hip muscles and abdominal muscles are also very important for aligning the pelvis. So remember I said that if the organs sit here and your abs are weak and your pelvis goes like this, you can imagine what will happen to those ligaments that are connecting to this bone here. The bladder connects to vesicle, what's the name? The ligament between the bladder and the pelvis is right here. Okay, so when the pelvis goes like this, because abs are very weak, that ligament will have more stretch on it. So you can see how if I change the contraction pattern of abs and if I change the contraction pattern of hamstrings and glutes, how that will change the how I use this pelvis in space. And because the ligaments attach to this pelvis, how that can change the alignment and the symptoms of the pelvic organ prolapse without changing the actual length of those ligaments. So abdominal hip strength will change how the pelvis sits. Pessaries, we'll talk about it in a bit. Pessaries are silicone devices that goes inside the vagina and hold the organs up in place. They are great for management of prolapse that is persistent. So grade 2, grade 3, grade 4. Okay. There are support garments that we can wear from the outside. I think there's a new one called pelvic bra, I think, by one of the pelvic floor PTs. And it kind of it goes like a bra on the pelvis, and it basically helps you give that external pressure from the bottom. And then we're going to talk about improving upward force, which is improving the health of these ligaments and this fascia. Ligaments and fascia are not muscular structures. We can strengthen them, but we can strengthen them or we can keep them from getting weaker by considering vitamin D and collagen health. And we'll get to that in a minute. Okay, and now last one is, can we distribute the downward pressure? So downward pressure going straight down into the vagina is going to overwhelm the pelvic floor more. But if we can distribute that force instead of parachuting down straight into the vagina, if we can distribute this pressure going to the side and going to the back. So if I stand up, all my organs are gonna go down gravity, right? But if I have good mobility on the sides of my trunk, if I have good mobility in my upper back, then some of that pressure will get disseminated in all directions, right? And it won't parachute down. This is what we see a lot in clinic. I see it is women who have round back and they kind of stay like this. Try it. If you're rounded back and now cough really hard, you'll feel more pressure into your vagina versus if you were to be a little bit taller and have your rib cage expand on all places. Now when you cough, the cough gets disseminated here, here, and here. So we want that distribution of the cough, of the weight, of the exercise in different directions. So when we have the mobility in upper back and rib cage, when we have mobility in our feet, it increases the chances of distributing that weight in different planes. When we are more limited in our range, we're more likely to create a parachute down of pressure into the pelvic floor. Okay? And we'll talk a little bit more about this when we get to the posture part. Okay, so these are pessaries, different shapes. Gaynor Morgan is great for any information about pessaries. You can look her up on the Instagram. Her handle is Pelvic Angel. She's in Europe, but she's a great resource for all things pessaries. All right, I'm going to go back to where I was. All right, so Can we prevent POP? So when we have all these risk factors and we talk about all the pressure management, it really gives us an illusion that we can control prolapse, right? If we do all the right things, the prolapse won't happen. We should know that prolapse happens to a lot of people who have perfect birth. It happens to people who have never given birth. It happens to very strong, very active people who know everything about everything. Pelvic PTs who have all the information, had the perfect birth, can still get prolapse. So, prolapse has so many factors attached to it that when we are preparing women for pregnancy and birth, we don't want to give them an impression that we can control it, because if they get it, then it'll be so disappointing and disheartening for them. We have to present prolapse in the light that prolapse has so many factors. We're going to do everything we can to minimize it, but know that it's also very common and it's not the end of your life if it happens, right? If 50% of women have prolapse, 50% of women are not disabled. They're not like dying. So, of course, it's a common thing, which when we think about it, makes us very scared, but it is a very common and very manageable condition. We'll do everything we can to avoid it, but it is common. If it happens, you will be fine. We will manage it, we'll take care of it. We talked about the modifiable factors, constipation, coughing, postural awareness. We'll talk about that a little bit more. BMI, osteoporosis, sarcopenia, hormonal health, postmenopausal, perimenopausal women, that's when they start to get a lot of prolapse worsening, when they start entering the phase where estrogen declines happens quickly. So a lot of women will come to me, have a grade 1 or 2 prolapse, and then 10 years later, as they're entering the menopause, they sometimes will have sudden worsening of prolapse, and that's estrogen deficiency. Non-modifiable factors are shape of pelvis, levator hiatus size, the shape and size of the perineum, and hypermobility conditions. So Ehlers-Danlos syndrome is highly correlated to development of prolapse with or without pregnancy. So if somebody has prolapse without pregnancy, their chances of being hypermobile is pretty high. It's also prolapse is also common after hysterectomies. All right. Vitamin D. So let's talk about vitamin D for a second. Let me get this out. All right. Vitamin D is crucial for skeletal muscle function. It's crucial for collagen formation. It's crucial for modulation of inflammation. And vitamin D receptors are present in skeletal muscles and connective tissues, okay, including pelvic floor muscles. The deficiency of of vitamin D has been linked to muscle weakness, reduced postural control, and even reduced collagen synthesis. Now we're talking about collagen because those ligaments and that fascia, that was the level 1 and 2 support, has collagen. Our bones have collagen, our joints have collagen, our ligaments, muscles, they all have collagen. Is the connective tissue that gives us strength, that holds things together. There are different types of collagen, and we'll get into that. But overall, all collagen synthesis is affected by vitamin D deficiency. Okay. Research has consistently linked POP with both occurrence and severity of vitamin D, which means women who have women who have prolapse and women who don't have prolapse, we're checking both. Women with prolapse tend to have more vitamin D deficiency. Okay. Also, women who have worse prolapse tend to have worse vitamin D deficiency. Now, this does not mean that vitamin D deficiency is causing prolapse, okay? And we don't have evidence for that at all. But it may mean that they were going to develop prolapse, or they developed prolapse, and vitamin D deficiency fed into the prolapse and it's worsening. Okay. And it's such a low-hanging fruit, right? Vitamin D is one of the easiest things to correct. It's also one of the most common deficiency because we just don't get enough sun. So women with vitamin D levels less than 30 ng per ml are significantly more likely to report pelvic floor disorders, including POP and incontinence. And it's very, very common in postmenopausal women and very, very common in postpartum women because we're feeding babies vitamin D. We're also making bones, when we are pregnant. So it really affects our vitamin D reserves. And if women are not replenishing those reserves while they feed their baby, they make their baby in pregnancy, they can get low on vitamin D. And imagine that's the time prolapse is happening, right? So now I have started asking my patients and my referral doctors to check for vitamin D deficiency at 3 months postpartum. And if they're not checking it, or even if they're checking it, we're keeping women on vitamin D supplementation. Okay. Conflicting evidence of supplementation helping PFM. So basically, there's some research. Now, we find that there's prolapse and we find that they are lacking in vitamin D. We give them the vitamin D back. That does not necessarily mean that their prolapse will go back, right? Because one, we don't know if vitamin D comes back, collagen gets better. Does that, or muscles get better? Does that necessarily mean that the organ will go back? So there's conflicting evidence. I think there was one research, and it's in the references, where they did the vitamin D supplementation for incontinence folks, people who have leaking, and their leaking did improve. So I think because muscle is a structure that changes quickly and has more capability of changing, we'll see a quicker change in incontinence people than in prolapse. But strength is also important in prolapse. So we don't have a lot of research to support that it will help prolapse, but we have some research to support that it will help pelvic floor muscles. And it is such an easy thing to do that why won't you, right? Okay, so that's my spiel about vitamin D. I will always have them in check, and I will just always have them make sure that they have enough. The more complicated part here is the collagen. Collagen is a little bit more complicated in this conversation because collagen is harder to replenish, and collagen is also collagen is harder to replenish, and also collagen is more variable in our body. Okay, so collagen is a primary structural protein that is formed in our connective tissue, but there's just not one type of collagen. There are many types of collagen. And what we see is there are a few things that we have seen in research. Women who have prolapse tend to have collagen that looks different. So they have done studies on ligaments. They've taken samples of ligaments from women who had prolapse, ligaments from women who did not have prolapse. They studied their collagen, like how they meet, like do they sit straight, those fibers, or they cross each other, the thickness of collagen, the type of collagen, and they have found that women with prolapse have altered collagen types. Okay, they tend to have more of type 3 collagen versus type 1 collagen. Type 1 collagen is the tight tensile strength collagen. Type 3 is a more flexible collagen that's kind of found in cartilage and other structures that have a little bit more give. And what we have found is that women with pelvic organ prolapse tend to have more type 3 collagen than type 1. So, is this genetic? Maybe, because there is hypermobility that connects to Ehlers-Danlos syndromes, hypermobility syndromes, connective tissue syndromes have high correlation with prolapse. So are they bendy all over their body? So they're also bendy and loose in their pelvis? Possible, right? Certain genetic factors, then hormonal influences. We also see that this collagen correlation gets stronger and stronger in postmenopause, right? So, and we know that estrogen is critical for collagen metabolism. So women, when they're breastfeeding, they have low estrogen, and postmenopause, perimenopause, they have low estrogen, could be affecting their collagen metabolism, right? Collagen remodeling. And this is a third theory here in research. We're saying, okay, so what if somebody has no genetic factors, no hypermobility or anything, and they are not perimenopausal either, they're not breastfeeding. They're young and they're past the breastfeeding age, they had a baby. Now, what if there was a forceps delivery, there was a vacuum delivery, or there was a normal vaginal delivery, but there was injury to these ligaments? They got torn, they got stretched. We see in body that when the ligaments get torn and stretched, there is inflammation and there is replenishing, there's healing that body tries to do. And we have some evidence to see that when the body replaces the collagen in the structures, it may not replace the type 1. It may not be able to replace that thick tensile strength tissue. And the body may be able to only replace it with stage 3, type 3. So it's also possible that injury caused the altered finding that we have in the ligaments. And I'm telling you all this because I don't want to give you an impression that, oh, collagen is weak, so let's fix the collagen and everything will be good. Because collagen is very complicated topic, even from other perspectives of musculoskeletal medicine. We also see that nutritional aspects like vitamin C deficiency, zinc deficiency will change the collagen metabolism. So could that be playing a role? So it could be genetic, it could be injury related, it could be hormone related, it could be nutrition related. Where do we go with that? And the trickiest part also is, yes, we know collagen is metabolism is a problem, type 3, type 1 is a problem, got it. Now, if we give them collagen back, we actually don't know that this collagen will make its way to the ligaments or fascia. Okay, because I know the collagen is coming up as a supplement and there's a market for it, but I don't want it to get to a point where women think that they're going to just take this special tonic of collagen and everything will be better, because companies will market it like that. They will. The meat and potatoes of our treatment and our management for prolapse is still exercise, right? And it's still pressure management and breath and all those things. Collagen can be a nice addition to an existing holistic program, okay? We can tell women, okay, we need to take, I'm going to get to the next page. We need to, if we need to make sure you have enough vitamin C, you have enough zinc, you have good sources of protein, or maybe you add a collagen peptide to your diet if you can manage it, and make sure you have enough vitamin C and zinc with it. Okay. Let's do that and create a more holistic environment, especially in postpartum when their body is changing and hormones are changing. Let's do all that along with exercises, right? So we are always combining it with exercises. And if somebody cannot tolerate collagen, like collagen peptides give them gastric upset, don't make them feel like they have to take collagen. Collagen can come from different sources. Our body can make collagen. We don't even know if collagen gets to the ligaments. So even though it can be a nice addition, we don't have to have supplementation. We can get it from our diet. Okay. I keep moving my window so I'm not blocking you. All right, so this is the medical management quickly. We generally, a woman with pelvic organ prolapse, if you're a trainer and you hear her talk about these symptoms, they will go to their provider. It's a gynecologist, urogynecologist, or midwife. In US, they can go straight to a pelvic floor physical therapist as well. They will generally do an exam, a speculum exam, to properly grade which organ it is, what level it is. If you're a pelvic floor therapist, you're going to see, is their pelvic floor too tight? Is it weak or is it healthy? It could be completely fine. Then they may get a pessary that will hold the organs up. And then go back to pelvic floor therapist and training. And if nothing works, surgery is an option. Okay, we talked about this. Okay, last one. Will it get worse? Everyone says, I've heard doctors say it, I have heard PTs say it, that grade 2, then grade 3, then grade 4, like that's the progression. And if it is grade 3 or 4, doctors will often say it, if it's grade 3, if it's grade 2 right now, go live your life. When you're done having kids, just come back and I'll fix it, because it'll be grade 3 and grade 4 at some point. We don't know that. In fact, there's enough research now to support the fact that pelvic organ prolapse not only does not get worse all the time, it actually gets better. Not in postpartum women, it gets better so much. even in postmenopausal women, it gets better. So with proper nutrition, with proper exercise, and some weight loss, we have seen that pelvic organ prolapse can actually improve. Not, and so many women who do all those things in my practice will stay stable. So we have no reason to assume that the prolapse will get worse. In fact, we have a lot of evidence to say that prolapse can get better. The poor prognosis is for prolapse that is grade 4, right? So if the organ's coming out, it's a big injury, the likelihood of it returning is less, grade 3 and 4. And the age-related prognosis for uterine prolapse. So if the bladder is fine and rectum is fine, but the uterus itself is descending, tends to have slightly poor prognosis. And that's because uterus is at the top of the vagina, right? So uterus is here. This is the vaginal canal. And bladder is here. Rectum is here. Bladder prolapses from here. Rectum prolapses from here. When the uterus itself is sort of prolapsing, you can see how the whole vaginal canal will sort of fold over, and that folding over will generally cause the weakening of the other structures too. So uterus itself is a supporting structure for bladder and rectum, which is why hysterectomy increases the chances of prolapse. So when there's uterine prolapse without bladder or rectum, that probably is some indication that there's some genetic factors at play here. Okay, and they tend to have slightly poorer outcomes. So if you have someone with just bladder prolapse, just uterine prolapse, high grade, you know, maybe we need to be a little bit more protective of those patients. But somebody postpartum, somebody bladder prolapse grade 2, we don't have to give them the idea that the prolapse is going to get worse because we don't know. Hope is more powerful than fear. And I say this so many times in this lecture because women, when they get worried, they get worse. And when they get empowered, they get better. A thing that is present in 50% of women cannot be very, very, very bad. Otherwise, 50% of women would be lying down, not doing anything, right? So we are finding prolapse more, we are diagnosing it more, we're talking about it more. And sometimes we're leaving these women until they get to grade 3 and now they're scared. So if we catch them at grade 1 or grade 2, we educate them during pregnancy, we educate them in postpartum, we educate them in perimenopause, they will not get to grade 3 or they will go from grade 2 to 1. So we have so much ability to change their trajectory before any of this happens. We have to give them hope. All right, core pressure systems. Does anyone need a break? Do you guys need a break? All right, so if no one says they need a break, I'm going to continue. All right, let's go. Core and pressure systems. So this is the basic of how intra-abdominal pressure works. Intra-abdominal pressure is a term that has been thrown around on social media in fitness world and healthcare very easily. You will see people get this handout from their doctors or from their surgeon saying, don't do anything that raises your intra-abdominal pressure. Don't do exercises that raise your intra-abdominal pressure. So we have to understand what intra-abdominal pressure is, how it works, and then we have to see how we can modify it and why is it such a big problem for prolapse. Okay, so imagine there is a balloon in my stomach. Okay, the muscle underneath my rib cage is the diaphragm. The muscle inside my pelvis is the pelvic floor. And then the muscles in between are my abs. Muscles in the back are my lower back muscles. Anytime we contract these muscles, anytime we contract our abs, contract our pelvic floor, contract our back muscles, contract our obliques, or take a deep breath in, we will create pressure in this system. Okay, so we will create pressure. This pressure creates a hugging motion, creates a stiffness around our trunk. That makes our trunk, our spine, stable. It makes our trunk stronger. So if I'm going to lift something very heavy, I don't want to be lifting from each and every part of my spine. I'm going to engage my abs so my trunk becomes a little bit more stiffer and stable so I can move my spine as one piece. Okay, so anytime our abdominals contract, our trunk muscles contract, intra-abdominal pressure happens. Intra-abdominal pressure is good. It is good. You have seen people who lift really, really heavy. What do? They take a deep breath in, they hold their breath, they contract their pelvic floor, they squeeze their abs in. What do? They create a pressure inside their trunk that's going to hug their spine and their organs and protect them as they pick this thing that is heavy. Okay, so whether you're picking up your baby or you're picking up 250 pounds, whenever we pick something up or lift something up or do anything, our body will contract our midsection to protect our organs and our spine. That is intra-abdominal pressure, that pressure inside. That pressure is good. It protects our organ, it protects our spine, it makes us strong, it makes us safe. What it also does is when we have the abs squeezing and we have the diaphragm pushing down, it creates a downward pressure in the pelvic floor. So intra-abdominal pressure will create a downward pressure in the pelvic floor. If you have no pelvic organ prolapse, most likely your pelvic floor will contract and create equal pressure upwards and nothing will happen. You just have a pressure system now that you can use to lift something up. But if you have pelvic organ prolapse, you are trying to lift something heavy, your abs are squeezing, your diaphragm is going down because you took a big breath in and you're holding it, and your pelvic floor isn't able to create upward force, so the organs move down. Okay, so intra-abdominal pressure is good, but sometimes that intra-abdominal pressure is overwhelming our pelvic floor. So we can't not create intra-abdominal pressure. Every time I bend over and then I come back up, there is intra-abdominal pressure. If there wasn't, my spine would go all over the place. So given that intra-abdominal pressure is not avoidable at all, what we need to train people is how to create this pressure and not overwhelm the pelvic floor, and how to create that pressure and know when they're overwhelming the pelvic floor so they can stop. Okay, and over time, train the pelvic floor to take this abdominal pressure and also learn how to do different things without creating too much intra-abdominal pressure. So this pressure can get this way, it can get this. We talked about distributing that pressure, right? So we can distribute this pressure, we can create less of it. And one other thing we can do is we can create a pressure valve that can release some of this pressure. So that's where our breath comes in. Okay, so glottis is the thing that will help us. Glottis is the thing that acts as a pressure valve for the core. Okay, so we have this system that's creating pressure, right? Now, there's pressure There's downward pressure into the pelvic floor. Now, we don't want to give up this pressure because if we gave it up, we would get weak, we would get hurt, we would not be able to lift. So we have to create this pressure. Now, imagine this is a balloon, so I can't do it, but imagine instead of this tied up here, if there was a straw here, right? If there was a straw here, then as we create this pressure, we can let some of that pressure leak. And as that pressure is leaking, we can decrease the pressure that goes down into the pelvic floor. Okay, so we can use our breath as a pressure valve so that we can create pressure, create contraction, create safety, create strength, but also not overwhelm the pelvic floor. Okay, so I'll give you an example of this. If I'm lifting something and I'm lifting it over my head like this. Now, if I was, watch me, if as I'm lifting, if I took a big sigh, I would be unstable. I would not be very good. This is lightweight. I would not be very good at lifting. Now, if I took a big breath in and I held my abs tight, I would be very strong and good at lifting this weight. But now I have overwhelmed my pelvic floor. So we don't want to sigh and let all that pressure go. We also don't want to close the mouth and hold all that pressure in because the pelvic floor may not be able to handle it. So what if we find a way in between? The way in between is, what if we did, so as we are lifting and we contract our abs, what if we did, so now as I'm lifting, I'm able to create pressure, but I'm also not constantly pushing down into the pelvic floor. Okay, so glottis or breath is our, glottis is basically the vocal folds, is a way for us to manipulate this pressure. We can make it a little bit less, a little bit more, right? And if it's too much for pelvic floor, breathe out longer, open your mouth wider. If it's not enough for pelvic floor, if it's a contraction is not enough for you to move, more, keep your mouth a little bit closer. So we can do different kinds of mouth breathing or different kinds of timing of breath to change the pressure. Okay, so you can try this. If you do blow from your mouth like you're blowing a candle, you'll feel your abs go in. When you go like sigh, you will feel your abs relax. And try hissing, go most of you will feel your abs and pelvic floor lifting up. So we can use these different types of breathing strategies or different vocal cord strategies to manipulate the pressure. Okay, and I'll give you more examples of this as we go on. So this is actually the slide for the examples. Okay, so breath changes the pressure dynamics, like I explained, by changing the volume of air going in and out, or by changing the speed at which air is going in and out. Okay, so the pursed lip breathing is the most common strategy used because when we breathe out with pursed lip, the air is going out, but not very fast. So there's a pressure leak, but the leak is not big. So the pressure doesn't go away quickly. It goes away slowly, so you can still kind of create some pressure as you're doing the movement. Exhaling with exertion, so we're doing the hard part of the movement, and we can go. That exhale as the diaphragm comes up also brings the pelvic floor with it. I don't think I showed you this, but when this diaphragm and this pelvic floor, they work in a unison. When we breathe in, the diaphragm goes down, the pelvic floor, all the organs go down, and in response to this downward movement, our pelvic floor relaxes. And when the diaphragm goes back up, the pelvic floor springs back up, abs go in. So we can use this strategy of going up and down to create a little bit more strength in the pelvic floor. Okay, so if we used exhale with exertion, we're able to create a contraction or sort of ride that phase where the pelvic floor contracts with exertion. So exhale with exertion is the easiest strategy, the strategy that works the best for most people. Okay. Exhale before exertion. As the activity gets harder, we are lifting more, right? So we cannot exhale through exertion. So I'm lifting 10 pounds. Yes, I can exhale through exertion. But if I was lifting 50 pounds over my head, I would not be able to exhale with exertion. Okay. So I will exhale before exertion. So I go, and then I would hold the breath through that exhale. Is that more pressure in the pelvic floor? Yes, absolutely. But as we are progressing these women, their strength is improving and their pressure is distributing better, we may be able to use different strategy. So not every strategy works for everyone, but I'm going to give you all the strategies for all the people in different phases of training and rehab. So exhale with exertion are generally for people who are lifting moderate low weights, and they can sort of exhale and let that pressure leak as they're lifting. Exhale before exertion when they're lifting a little bit heavier and they really cannot let that pressure leak because it makes them unstable. So if you exhale before exertion, that exhale will create a pelvic floor contraction. So now pelvic floor is actively contracting. It may help it tolerate that downward pressure a little bit more. Okay. Inhale and hold. When we inhale, the diaphragm goes down and we hold. We pull the abs in, inhale and hold. That creates significant pressure in the pelvic floor. That is not wrong. It's not a wrong thing, but it is needed when you are lifting super heavy, right? If you're lifting your body weight, if you're lifting 70%, 75% of your best, you're getting to the point where you'll have to create that kind of pressure. Okay. So if you have somebody who is symptomatic, and they really don't want to give up that part, make sure that they have progressed to that part. But let's say they can progress, everything is going well, they get to this point, and no matter what they do, they will have some downward pressure. This is the time they should wear a pessary. This is the time they should wear external supports and some help to hold those organs up, because their ligaments are weak and they're creating all the pressure, they're creating all the things, doing all the things right. They want to lift heavy. That's their goal. We can give them a pessary, we can give them a passive support to let them lift heavy. And of course, lifting heavy, that doesn't mean that, oh, I want to lift heavy, so I'm going to lift heavy. They have done all the prep work getting to heavy lifting, and heavy lifting is really important to them. Talk about that in a minute. Inhale with an exertion. That's a different thing that I sometimes see, and this is for very light weights, right? If you have a woman who says, no matter what I do, I feel prolapse. Like I get up from my chair and I feel prolapse. And I bend over, tie my shoelace. Like I'm not feeling it here, but as soon as I bend over to tie my shoelaces, I feel prolapse. Or as soon as I get up, as soon as I do even like a wall squat, I feel a prolapse. So if minimal activities are making them feel prolapse, there is a chance that they're over recruiting their pelvic floor. They're tightening their pelvic floor more than necessary, and that's creating a sensitivity that's making the prolapse more symptomatic. Remember the prolapse, squeezing the pelvic floor around it. So they're doing that. So sometimes with these people who are symptomatic no matter what, and you can tell by their presentation, they're very worried, they're very they're very worried, they're very distressed by this prolapse. So if you have someone like that, I will tell them, inhale with exertion. When you do tie shoelaces, inhale, take a deep breath, inhale, relax. Let all the pressure out. Of course, we're not doing this with actual lifting, but this may help her feel that, oh, like contracting doesn't always help. Sometimes relaxing helps. So they may actually need to learn how to let their pelvic floor go before they will learn how to contract their pelvic floor. Okay. Nose breathing versus mouth breathing, because this question comes up every time. Mouth is easier to manipulate because we have vocal cords. We can change the way we use our mouth and change the way the vocal cords will shape and change the pressure. Nose breathing is better for workouts, just for life, but it does not give us the same manipulating strategy. So when we're working with somebody with strengthening their body with pelvic organ prolapse, I'm usually using a mouth breathing strategy. Now, when they're completely symptom free with mouth breathing for low weights, moderate weights, you can definitely go to nose breathing after that. Their system has learned, their system has strengthened or figured out a way to find an equilibrium. You can definitely go to nose breathing. But mouth breathing is easier to manipulate, it's easier place to start, especially for people who have a hard time relaxing. Hard time relaxing, they're always contracting, they're always symptomatic, no matter what they do. Easiest thing for them to do is big mouth sigh, let all the air out. Train the breath. Okay. This is my most important thing I do with pelvic organ prolapse people. Okay. And if you're a trainer, you need to know this. You need to give them homework to train their breath. If you're PT, you need to do this. If you're a PT, assess their rib cage, see where they're limited. A lot of people are very, very limited in their posterior mediastinum. They cannot expand in their posterior lungs. Okay. And if you're a trainer, you might see that they breathe just up here, right? And those people will generally have more pressure. No matter how many Kegels you do, if somebody does not know how to breathe, they will always create altered strategies and generally will create tightness of pelvic floor, which in long term just makes them feel worse. Okay. So our ideal breath is a breath that goes all 360 degrees into our trunk. So when we breathe, I will often say, imagine there's an umbrella around your trunk. When you breathe, that whole umbrella should open up. The front should open up, the side should open up, and the back should open up. Okay. And most people, the common pattern is most people breathe up here. So, and you will see their belly goes in instead of relaxing. The second pattern is some people who have learned belly breathing, they will go like this. They will expand their belly. They will kind of blow up their belly as they're breathing in. And you can imagine, if you remember that balloon I had, somebody who is only doing this belly breath is actually creating some pressure down into their pelvic floor every time they inhale. So if their body does not know how to breathe everywhere, then all the air goes right here. And it goes right here, it goes to the vagina. If they learn how to breathe into their lateral rib cage, and if they learn how to breathe into their posterior lungs and posterior mediastinum, some pressure will go here. This expansion will happen. Some pressure will go down into the back side of the pelvic floor and not just come into the front. So the ideal strategy is umbrella breath. One thing I use to train people for that is have a strap go around their bra strap and basically ask them to breathe into the bra strap, all sides of it. Not much movement is seen. It's not a deep breath, but they should feel that they can expand in the back part. And then you can move this belt up into the different part of rib cage to train them. Okay. Most people do not know or have a very hard time breathing into their upper back, this part. And that comes from us holding our babies like this, comes from us holding a good posture where like, so we lift our chest up. And if you lift your chest up, your backside of your lungs and rib cage is now compressed. It cannot open. So you have this chest lifted, your pressure is going here, you feel your vagina falling out, this is closed in, this is tight, and this is tight. We see this pattern, tight, 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 pressure, pressure, pressure. These people, if you have them take a pillow and push into the front of their rib cage. Okay, tell them to pull their rib cage in and put a pillow on top so they cannot breathe into the belly anymore. Okay, so compress the front of the rib cage, look down, and ideally I would not be doing this standing. You'd be seated or like a child's pose position. I'm going to show you in standing is to compress the front, go down, look down. Tell them their arms have big weights here, so they cannot lift their shoulders, right? So it has to stay down. And tell them to breathe into the space between the shoulder blade. So imagine there's a line between the two shoulder blades, and as you breathe, that line gets a little bit bigger. Okay. Sometimes you don't even have to say anything. If they have a good enough compression in the front and they're not lifting their shoulders, so they cannot breathe into their shoulder, like upper the cervical spine, and they cannot breathe into the front because they've compressed it and they keep this compression. Only place that the breath can go is back. So training posterior breath for people is not easy because one, they feel like they will round their back, they lift their shoulders, they do all kinds of funky stuff to try to get their back to round. Most of the time, I'll say, hold this position, go down, imagine that line, and just breathe. Okay. As long as you're holding here and you're not letting the front of your chest expand, you're still alive, so you're still breathing, your body will find the way, will find a space where the breath can go. So instead of telling them breathe here, you can't tell them breathe here. Try to take away all the other options and they will have no option but to do the posterior breath. So I really teach how to compress the front of the rib cage, how to get this down, shoulders down, and then I say set a timer for 3 minutes and just breathe. Okay. And they will often say to you, I feel like I'm short of breath. I feel like I can't breathe. I feel like I'm dizzy. And that's because they are getting less volume of oxygen into their body because their lungs are struggling. So tell them, come up. You're going to yawn a few times as your body resets and then go back down and try again. And over a period of time, you will see and they will feel that they can expand the backside of the lung. Okay. Most people do not know how to exhale completely. Most people have a diaphragm that is stuck in somewhat of an inhale. So when we have the diaphragm that goes down, inhaling, and then when we have it exhale, it comes up. Most people have a diaphragm that does not go back to its resting position. It's kind of stuck in down here position. And that is a result either of tightness of their chest, like lifting their chest up, tightness of their rib cage, stress, like holding their body like that, or sometimes just the pure weakness of exhalation mechanisms. Because part of the exhale, so when we inhale, the diaphragm goes down. When we exhale, the diaphragm goes up. 70% or 60% of that exhale is passive, it just goes up. Last bit of that exhale is very much active, right? So when I exhale, I didn't really use any muscles, right? Diaphragm just went back up, it's kind of passive. But if I have to empty all the air out of my body, what will do that? What will do that? Try it. So you go. As you get to that end of exhale, you'll feel your abs working to push the air out. You should feel that. Most people do not exhale completely because they do not have deep abdominal control and awareness to get a complete exhale. People are so focused on belly breath, they take an inhale and their exhale is half. And you can see how important an exhale is because when the diaphragm goes up, when the diaphragm goes up, what does it take with it? Pelvic floor. What does it take with it? The pressure, right? So the diaphragm going up is a very important mechanism to decrease the pressure into the pelvic floor. So please train people to exhale completely. Please train people to exhale completely, okay? a lot of people, so I will usually say you should train to exhale for 7 to 10 seconds or longer. When you tell people that, when you tell them to exhale for 7 to 10 seconds or longer, a lot of time you'll see this. This. Okay, so this is my belly. They'll go. So they're exhaling using their upper abs and creating a downward pressure into their lower abs and pelvic floor. So we want to train the exhale, but we want to train that exhale with a deep core engagement, which is our next topic. Okay. So in this page, we want to remember the takeaways are we want to inhale all directions, special emphasis on posterior mediastinum. We want to exhale all the way, special emphasis on using the deep core, not just the upper abs, or using the entire core, not just the upper abs. Okay. We can also train resisted exhalation, which is what blowing into a balloon or blowing into a straw. And again, before we get to resisted exhalation, we have to establish a good core pattern. If they are using just this part and they're engaging this and creating this bulge in the belly, that is the pressure downward. So that's doing the opposite of what we want to do. So we want to train a good exhale, but we want to train the exhale that starts from here. The ab contraction starts from here and goes up. So we want to see. We want to see that. All right. So we will talk about that deep core contraction, the good contraction that takes the pelvic floor, transverse abdominis with it, which is the contraction we want. Okay. Now, everyone has probably felt their pelvic floor in this class, but we're going to quickly do this so you can feel the pelvic floor if you haven't. I want you to sit in a surface where your knees are about 90 degrees, maybe a little bit higher. Okay. I don't want you to be like this. I want you to be relaxed. I want you to put your hands under your butt. And then I want you to swing side to side. And you should feel that you're sitting on 2 sit bones. Yeah. Now keep sitting on those sit bones. Move your hand and slowly, just very, very tiny bit, like 3 degrees, come off those sit bones. Okay. I didn't do this. I was sitting on my sit bones and then I came off the sit bones. You should be sitting on that skin between your vagina and your anal opening. Okay. Or if you're a male, between your testicles and your anal opening. You're sitting there. That part is perineum, and the meat of your pelvic floor is underneath or above that skin. Now, sitting there, I want you to breathe in. Imagine that that skin softens and pushes down or kind of sinks down into the stool as you breathe in. You breathe in, and here, if you take a belly breath, it'll be easier to feel because there will be pressure downwards. And then I want you to blow out from your mouth. Think of scrunching that skin up, okay? Or you can think of like you're sitting on a blueberry, and as you breathe out, pick that blueberry up. As you breathe in, let the blueberry fall. As you breathe out, pick the blueberry up, okay? Some people will say, imagine this is an elevator that you're sitting on. As you exhale, go up the elevator. As you inhale, come down the elevator, okay? A jellyfish is a common one, like jellyfish kind of expands and then contracts and expands and kind of helps women. When you teach them like a jellyfish, they kind of understand in relation to the diaphragm because the diaphragm domes, comes up, diaphragm flattens, relaxes. So that might be a good analogy to teach people. Okay, so now that you have felt your pelvic floor, I'm gonna give you a couple of different ways to bias the pelvic floor. So this isn't specific to this particular course, but I think it's a good thing to know, especially if you're dealing with bladder prolapse, because these women will often show a pattern. They will squeeze the rectum part, the back part of the pelvic floor. So This was the pelvic floor, right? They will squeeze or they will engage this part of the pelvic floor much more than this part of the pelvic floor. So they will pull from here, but they don't create as much pressure here, as much contraction here. So a way to bias the contraction into bladder is to think, is the cue is nod your clitoris down. So clitoris here, or if they're lying down, it's nodding down. But if they're standing, nod their clitoris back or nod their clitoris inside into their body, and then use it as a claw to pull something in. Okay, so I'll say breathe in. So this was my clitoris. This is my clitoris, right? I'll go breathe in. As you breathe out, breathe in, unnod and let go. Breathe out. This cue of nod the clitoris down and use it as a claw to lift up, pull something in, is a cue that I have found very successfully gets people to engage the front part of their pelvic floor and their lower abs. If you did this with me and you did this to the end of that contraction, you should have felt a contraction of your transverse abdominis down here. Okay, so nod and pull gets the anterior part of pelvic floor to contract. That works very closely with transverse abdominis in the lower part of our abdomen and is very helpful for creating lift in the vaginal canal. Okay, when we say hold your gas, or we say pull the rectum to your belly button. So if rectum is here, I don't just pull it up into my back. I actually pull it up and forward towards my belly button. So when I say pull the rectum up and forward towards your belly button, will create more contraction in the back side of pelvic floor. Okay, that typically works well glutes and hamstrings. Now, anterior also needs glutes and hamstrings. We do. But very often, especially if you're a physical therapist and you do a vaginal exam, you'll find that the vaginal opening is here. You put your finger into the exam and you'll feel the bottom is coming up like really strong, lifting your finger, and top's not doing that much, right? We want to feel the whole canal close and pull my finger in. That's what I want to feel in the exam. If you're feeling the bottom comes up and the top is kind of lazy, then the cue I would give is let your sacrum go, let it relax, nod the clitoris and pull up and in, and you'll feel the top part of their pelvic floor come in. Now, back part of pelvic floor is anatomically stronger. So if you're asking for a lot of contraction, squeeze as hard as you can, pull as hard as you can, you're more likely to see the back. Okay, so when we're trying to bias that and teach them how to contract the front of their pelvic floor to support the bladder, we have to say do less. Do like 50% of your best, but do more of this. Okay. If we are looking for superficial muscles to contract, a cue that helps is think of closing the vaginal curtains. So imagine there are curtains at your labia and close those curtains. Now, this isn't a cue that's really necessary in prolapse because prolapse is more about lift than squeeze, but just so you have it. And the deeper part of pelvic floor, the contraction, the cue that works the best is lift. Sip a smoothie from your vagina. Imagine a tampon's falling out, you're pulling it back in. Imagine there's a blueberry on your outside your vagina that you're trying to pick up. So lift, pull is the contraction that gets the levator ani, the meat and potato, the deep part of the pelvic floor to contract. Squeeze gets more the sphincters and the superficial muscles. So when you're cueing, if you're cueing pelvic floor, use the terminology that goes lift, sip, suck, right? Like going up and in, and then you can use the strategies to go front and back. One other thing that helps sometimes is if you shift your weight into your toes, and you can try this now. If you're standing and you shift your weight into your toes, the ball of your feet, and then do a contraction, pick up a blueberry, you'll feel more front. And if you shift your weight in your heels and then do a contraction, you'll feel more back. And that's simple. Our pelvic floor reacts to gravity. Organs are falling down, gotta pick them up. So if your weight is forward, organs are falling in the vagina more, so the vagina will contract. If you're back, the organs are falling more in the rectum and rectum will contract. Neither one is bad, but this can help you understand when women are holding their babies and like doing this and the weight is all in their heels and now they are doing pelvic floor contractions. What are they doing? The rectum and the butt. And they're not doing anything here. If anything, they're creating pressure by creating this line where the pelvic floor on the front is extra stretched and have the baby on top, right? We'll talk more about posture in a minute, but getting people to understand where they keep their weight is going to change where the pelvic floor contraction goes, because pelvic floor basically responds to gravity. As soon as we stand, things fall down and your body's like, whoop, gotta pick them up. Don't let them fall down. So when we change where our weight is, that changes where the contraction goes. All right. Next page. All right, we already talked about this core contraction. Now, this is more important to understand because there are people who will engage their abs in a way that they create more pressure in their abdomen. So they contract like this, right? So if they're contracting, or you can try this, if you blow a balloon and you go, right? So we're we're contracting upper abs. We're contracting upper abs without contracting lower abs. So the pressure goes into the lower abs. Now, before you were pregnant, before any of this happened to women, when we contract the upper abs, lower abs come with it. They just do, right? So we don't see this problem in little kids. We don't see problems in often in non-pregnant women either. This becomes a bigger issue in postpartum because our lower abs get stretched, our pelvic floor gets stretched. So this balloon that was nice and tight before now is tight here but loose here. So now when we ask for a contraction to blow a balloon or to exhale, it's easier to find this contraction and it's harder to find this contraction, which is why we have to train women to find their pelvic floor and lower abs, because it's going to create that upward movement from down here. Okay, it doesn't come as naturally and easily after pregnancy that it did before. So this is the cue to get their core to fire more uniformly. We're going to breathe into all sides of our trunk. Okay, breathe in. It doesn't have to be a big breath. Usually keep their hand here or right above their belly button, not on their belly button, right above their belly button. Breathe in, normal breath. As you breathe out, blow a candle. As you blow a candle, think of pulling something inside your vagina. Imagine there's a blueberry falling out or tampon falling out. Pull the tampon in and then think of wrapping your pubic bones around that. Okay. Analogy I'll sometimes use is a diaper, like you're pulling the diaper, the bottom of the diaper up, and then you're wrapping the sides together. Okay. So it's going to look like this. And generally, I don't really have to cue the upper abs. They come in as they get stronger. It's the easier part. We don't really have to do much unless they have a big diastasis here. That's a different thing. But for most people with pelvic organ prolapse, lower abs and pelvic floor have a hard time coming into the contraction. Upper abs come in easily. Okay. So when you do this, what you should see is a uniform flattening of the belly, even though I never said suck your belly in. You'll see that the lower abs lift up and in and flatten. I did not say flatten the belly. I said lift the belly. But as they lift the belly will flatten more uniformly and then come up versus which is bulging. So once we get this contraction, right, we get this, they feel it, they know what it is, it starts here, it moves here. Then we can tell them, now work on making your exhale longer, stronger, right? So we have this, good. Now can you do it longer? Now can you blow into a straw? Now, can we put that straw in a smoothie, hard smoothie that you're going to have to push a little bit harder? And then you blow a balloon. Balloon is honestly very hard. So once we get this contraction and we keep moving up this contraction, then we can add the resistance to keep the diaphragm going up and using the abs to get a full exhale that we talked about. Okay, so this tandem movement of core is very important because it is protective for pelvic floor, brings the pelvic floor with contraction, which is not automatic in most postpartum women. Okay, and postmenopausal women are often postpartum because they had kids, and they don't always get that. So we have to teach that. So we teach this, right? Then we reinforce a good inhale on all sides, especially back, and then we reinforce long exhale and resisted exhale while keeping this. So they never breathe up here, they never blow their belly out, push their belly out, and they never they never lose their pelvic floor contraction that they started. Okay. This is a demonstration. I already demonstrated, but here you go. Breathe in. And you can see my belly comes up and goes in. I was pregnant at this time, not very pregnant, but you can see how I'm thinking. I'm not, those bones don't move, but my cue is close your pelvis like a book. And that kind of creates this lower ab contraction. Okay. This is a picture to show. The second picture is that overactive rectus abdominis, which is what I said, overactive upper abs. You'll see that they have this, you'll see sometimes women who have um, like an indentation here, right? They have an indentation here, but they have a bulge here. And that they're gripping and keeping this in, thinking that this is strong, but all it's doing is driving pressure down, creating more pressure in the pelvic floor. Okay. So first one is relax abs, second one is upper ab overactivity. That's kind of what we want to avoid. And if we see that, we scale them back, we teach them breath, we do all the core coordination stuff. Number three is what is more than 30% maximal contraction. Kind of want to see this as if somebody can do this 30% maximal contraction is the time. That's what you will see when you tell them to breathe out completely, breathe out more, 7 to 10 seconds, breathing into a balloon, into a straw, you'll see that this muscle is contracting hard to push all the air out. That's what we want to see. And then fourth is a more uniform contraction. That's kind of what we will start women with. We'll see that one more often than not when they're starting and we're teaching them how to do this, which is not usually, it's like not a very strong contraction. It's like pull the pelvic floor up, side, wraps the side together. Doesn't have to be very strong, but should be a good quality, which is what the fourth one will be. Simple. Yes, we explained the whole thing with the balloon. This was simple to understand, good to understand, but we know that our trunk is not a balloon, right? The difference between trunk and a balloon is trunk changes. Our organs are filling, you're eating, we're peeing, our poop's going through, right? It's also a mix of air, solid, and liquid. So there's structures that are passive, there are structures that are active. So even though this is very simple to understand, this is not exactly how it works. And I want to put this disclaimer here because we can show this, but there's times when all of this works and still the symptoms are there. So we have to know that it's not that simple. Right. So we're going to talk about factors that affect intra-abdominal pressure and prolapse. This is the third section. We're going to talk about how posture affects it, how foot affects it, hip affects it. A lot of those things I've already talked about, so this section should be a little bit quick, and then we're going to get into the exercise and the movement sessions. Right. So alignment, we know that diaphragm and pelvic floor sit like this. We know that diaphragm goes down and pelvic floor goes down with it, and they contract together. We know that part. So when two things have to contract and relax and move, not contract, relax, and move together, it's ideal that those things should be in a vertical relationship, right? So they should not be, if they're here, they should not be like this or like this. They can be, they will still work because gravity is still there. But if they were in a somewhat of a vertical alignment, the theory is that contraction will be easier, okay? So alignment or posture affects pelvic floor by two ways. One, when our diaphragm is really out of alignment from our pelvic floor, it makes it, so if I'm here, or let's say I'm here, it makes it much easier for the back side of my pelvic floor to engage than the front, right? And if I'm here, it makes it hard for me to engage my pelvic floor because my rib cage is not settled on it. So posture affects pelvic floor mostly by stacking mechanisms. Now, if we have loss of verticality between diaphragm and pelvic floor, between rib cage where your bra strap goes and leggings where your pant straps go, if those two straps, the circles, the rings made by those two straps don't line up or they're completely out of alignment, then it's hard for that communication between the diaphragm and pelvic floor to happen. Right? And that's what happens in pregnancy. You can see on the right-hand side picture that the pregnancy really pulls us forward. So now the back side of the diaphragm has verticality with the back side of the pelvic floor. So we will see that the back side of pelvic floor gets tight and we get tight glutes, we get tight SI joint, but the front side of diaphragm or front side of pelvic floor is literally has nothing on top of it. So that relationship is often lost, and that causes poor ability to engage the pelvic floor in the front, along with the stretching that's already happening because of baby. Okay. Now, I don't want to make it sound like it has to be vertical. If it's not vertical, everything's going to fall apart. That's not true. I want to give you perspective in a way that, okay, if somebody's standing like this because they think this is good, then maybe you want to bring some attention to the fact that maybe this relaxing this will help them engage this part, right? Because women stand like this, pull their belly in and drive pressure down into their pelvic floor. If you're lifting your chest up and you try to engage your abs, the abs you're going to get is upper abs. Try it. Right? So when we get this down, we get a little bit more lower ab contraction. So, or if somebody's here, we want to kind of encourage them to get a little bit up. Now, I don't really believe in the perfection of posture. I don't think it has to be perfect for you to do things. But if we give people a general idea of this, they start to change, or at least whatever they thought was good, they may change that and come to a more neutral alignment. All prolapse is not same. You can see these two presentations. Both of these women will generally have symptoms of something falling out of my vagina, leaking, pressure, whatever, right? Everyone's prolapse symptoms can sound similar. But one is an extended system. The first woman is a very common postpartum or pregnant woman, right? The belly pulls them forward, they fall into an extension, and when the belly is gone, it's replaced by a baby. So their typical pattern is they stand on their heels, right? So they stand on their heels, their knees are locked, their back is extended, and they use their pelvis as a shelf. And this system creates downward pressure, right? That makes sense. The second woman is a very common postmenopausal woman. You'll see that they have some osteoporosis, they have some sarcopenia, they're losing muscle, they're losing bone mass, they're bent over because their balance isn't good, they're holding on to things. So you'll see that they are rounding their back, right? Now, for them, what we see is that they're dumping the upper body weight into the pelvis. Like the upper body is not holding up for itself. It's just a free weight falling into the pelvis. And if a free weight is falling into the pelvis is going to have more pressure. So the second person needs to get off that pelvis. They need to actually learn to extend their spine. They need to learn their lats to engage. They need to learn their biceps and triceps to work. And you can see how this woman, the second woman, can do a lot of prolapse rehab and prolapse exercises in sitting position. She doesn't have to move her leg. She has to sit down and learn how to get off, how to separate this upper body from her trunk. So she has to open up more of her front diaphragm. She has to learn to expand her lungs. She has to learn biceps, triceps, pecs. She has to learn to get her lats engaged. The postpartum woman, on the other hand, is over engaged. She's always tight. She's always doing something. She needs to get to a wall and let her chest down. She needs to actually look in the mirror and see where her pelvis is. She needs to take her hand and push her pelvis back. Okay, so I'm going to go over the correction for both of these postures in a minute, but this should kind of explain to you that when you see somebody with with prolapse, it's not just about pelvic floor. It's really about their pressure systems. We have to see where they are. All right. So we're gonna practice correcting both of these posture. I'm gonna leave this here. Okay. All right. So this is a little drill that I teach my patients. All right, so this is the first person. The postpartum person typically has her pelvis is shifted forward, okay? Her chest is shifted back. She very often has a rounded back because she's nursing, okay? And she's looking down at her baby, so her cervical spine is, her neck is kind of forward. Her weight often is in her heels, and she has locked her knees. And I'm generalizing, but I'm giving you examples so you can apply it to your population. So weight in heels, locked knees, tucked, shifted pelvis, engaged glutes. They'll often say, I'm squeezing my glutes all the time, and I still have flat glutes. Baby in hand, looking down. So this person, I'm gonna give the cues, okay? And you can practice this. You can get into this position and then practice this with me if you want. First thing I want you to do is I want you to shift your weight into your toes. And then I want you to shift your weight into your heels. So do that a few times. And then I want you to go into your toes, come back to your arch. Don't go all the way back to your heels, come to your arch and stop right there. So when your weight is in your arch, ideally your knees will be unlocked. That will happen. Okay, that should happen. If it hasn't happened, then they have severe hypermobility. At that point, you want to have them just soften their knees. So weight in the arches is very, very important. And then we have soft knees. Then we're going to tell them, generally, their pelvis is here. I'm going to tell them put two hands on your pelvic bones and gently, just like 2 centimeters, push this bone back. Okay. Just even this much will automatically get them out of the locked knee position. Okay. Now, if they have a huge pelvic tilt, you can cue them to make their tailbone a little bit longer. I tend not to do that because that makes people just sort of they can do this, and that's not useful. So I don't cue a lot of this thing, the pelvic tilt, I just cue, get out of this thing. So just, it's just a pushing the pelvis back. And then I'll say, put your hand on your chest and put your hand on your pubic bone. And I want you to think about bringing your sternum, your breastbone, in line with your pubic bone. Keep the weight in your heel, in your arches, keep the knees unlocked, and now you have this, okay? And 100% of time they'll say, oh my God, I'm falling forward. That is so slouched. I feel so horrible. My posture is so bad. And we have to encourage them to understand that this is not straight, okay? And then I'll bring them in front of a mirror and then I'll explain to them that now that they feel forward, now what the forward feeling is actually the true forward, which is forward head and forward shoulder. That's the only thing that's forward now. Everything else is neutral. So now you really feel forward. They'll often feel tightness in their neck because now you're not compensating for the tightness of the neck by shifting your pelvis. So at this point, I will often say, bend your elbows and turn your forearms out. And that will sometimes help them bring that scapula into a little bit neutral position, not even all the way out, halfway out, and then leave the shoulder blade where it is and relax. And then slowly we can work on getting the cervical spine back. But that's like a whole thing. I don't want to give them too many cues. But for in the beginning, I'll say, I know you feel like you're falling forward. It's okay. Look, when you feel like you're falling forward, now try engaging your pelvic floor. Now try doing that core contraction. See how easy it is to engage this. And once I show them, go here and engage this, and go here and engage this, they're sold. Then they will do it, even though they feel like they're forward. And I'll tell them to go stand in front of the mirror 4 or 5 times a day and sort of do this. And I will not make them feel like standing like this is horrible. It's going to make their organs fall out. I'll say to them, if you keep going back to this during the day, eventually your body will sort of feel comfortable here. You won't feel like you're falling forward. But if you're holding your baby for 45 minutes, you're going to go here and it's okay, right? So when we want to teach them posture in a correct posture, but we don't want to make it like a psychotic thing that if your pelvis is not in right position, your organ's going to fall out or your diastasis is going to get worse. So give them some perspective. So that's the first person. Now the second person is this one. Okay, they're often standing in their toes. They will feel like they can walk really fast, right? If you're a PT, you probably know people who have poor balance actually walk faster because they can't control their weight easily. So they're falling forward and they're kind of on their toes already. So this person, I will shift their weight, get them into their arches, okay? And then my cue usually is, imagine there are two grapefruits between your armpits, okay? And I want you to squeeze those grapefruits and show the world your chest, okay? So we're gonna squeeze and lift. We're gonna get their lats. And once we get the lats, usually the extensors come with it. And then we can teach them here to breathe more and expand more, okay? So lat work will generally get these people to extend. I cannot emphasize how important lats are in postpartum prolapse, in postmenopausal prolapse is very important because people, when they dump their weight forward, it forms like a parachute down. And once we get them up here and expand here, now they're able to feel the pelvic floor more. And also their pelvic floor doesn't have as much weight, okay? So grapefruit, squeeze the grapefruit and lift your chest up to the world or expand your chest up to the world. All right. All right. Overactive pelvic floor. Overactive pelvic floor and prolapse is a thing that we have talked about in recent years. For a long, long, long time, it was all about pelvic floor strong. It should be not be weak. Let's contract, contract, contract. And in recent times, we have seen that when the pelvic floor is too tight, it actually makes the symptoms worse. Okay. And we've talked about it as PTs, as trainers. We've talked about it. We've seen it a lot of times. My mentor told me this like 15 years ago, 20 years ago, but there wasn't that much research, and there still isn't. There's only one research where they took, and this is in your references, Anna Crowell, where she took 23 out of 33 women who had moderate to severe prolapse, and they received 5 treatments of just myofascial release into their pelvis. And they found that women had significant improvement in their prolapse. Now, this is a very small sample size. It's not a randomized controlled trial, none of that. So we don't really have a whole lot of evidence, but I can tell you from personal experience, people who have very tight pelvic floors have more symptoms, right? A tight pelvic floor is like a half-made fist, right? If I told somebody, squeeze your fist, squeeze my hand, a half-made fist can only squeeze so much, right? They'll be like, I can't squeeze more. You can't squeeze more because you're already squeezed. When the muscle gets to a resting length, it can squeeze more. And we see this. If you're a trainer, you already know when we get in a deep deadlift and our glutes get a stretch, when they get a stretch, they can explode and contract more, right? So getting a muscle to its end range actually helps its recoil. It helps its contraction. So why won't we that apply that to pelvic floor? Pelvic floor needs to relax to be able to contract. It even needs to stretch to be able to contract. So we have to understand that tightness of the pelvic floor is a big problem. If you, as a trainer, if you have someone who has never been to a PT, who has never been to a doctor, and they have prolapse, I highly encourage you to send them to pelvic floor PT, because we can tell you what their pelvic floor is doing, right? You can guess, we can sort of kind of understand their symptoms, but an exam is an exam. We can tell you front of the pelvic floor is not contracting, back is contracting, pelvic floor is very tight. She's very, because very tight people and very weak people sometimes look like exactly the same, because they say that I can't contract anymore. So try, if you're a trainer, send them to pelvic floor PT at least for a couple of sessions so we can tell you what's really going on. Menses and POP, we also know that the most people have slightly more pelvic organ prolapse symptoms around their menses, like menstruation cycle. Progesterone is high, ligaments are a little bit loose, pelvic floor is a little bit sort of lazy. Uterus is heavy, so it's pushing down. It's heaviest that it's going to be in the cycle, right? So most of my patients anecdotally report more symptoms leading up to menses and feel a little bit better around their estrogen phase. Now, doesn't apply to everyone. Listen to your client, listen to your patient. If they're saying they feel more symptoms, have them track it. If they're saying they have more symptoms, then maybe we want to track and find out it's around their menses or like PMS. Then maybe we don't want to do a new load or a new activity or a more complicated activity that tends to be symptomatic in that time. And if we are trying to introduce something which is difficult for them, we maybe introduce them in the estrogen phase, in ovulation phase. And if your client doesn't have any of those, then you can forget about it. Okay. But I at least 70% of time find some correlation. Okay. Foot and pelvic floor, I put this here because there was a meta-analysis. Meta-analysis are high-level studies. We can't ignore them, even though I don't feel like this always applies. When I try to do things in the clinic, it doesn't always apply. But this was a meta-analysis of few studies I mean, not recently, maybe 7 years ago. So I think it should be mentioned. Foot position and activation, the researchers took, there was a few studies where they have passively positioned feet in dorsiflexion, passively positioned feet in plantar flexion, and then neutral, or active plantar flexion, active dorsiflexion, or neutral. And what they found was when passively positioned in dorsiflexion, when the toes are up to the nose, it's easier to engage the front part of pelvic floor. Okay. And when we talk about actively engaging, like going up on your toes to engage the calf, or going up on your heels to engage the toes, pelvic floor activity increases in both. Okay. So anecdotally, I see that there's poor arch control and strength in the foot muscles for pelvic floor weakness people. So I often work on intrinsic foot muscle strength when I'm working with pelvic organ prolapse. But one thing that I have found useful from this slide takeaway is when we're doing like Pilates kind of movement, you're on their back and they're lifting their heads, or they're moving legs and their abdominal contraction is overwhelming their pelvic floor. What I often find helpful is putting a band around their ankles, around their feet, and having them pull their ankles up. And somehow that dorsiflexion creates a little bit more. I've seen this in my patients in ultrasound a few times, that creating that upward pull of the toes does help their pelvic floor. I don't have any evidence for it, but I have seen this a few times, and that's kind of where I end up using it. Okay, we already talked about hip and pelvic floor, about obturator internus and adductors. We also have talked about glute strength, hip extension and abduction, which is closely related to pivorectalis, or the back side of the pelvic floor function. So, and we will integrate this coming up. Spine and pelvic floor, we already talked about it. There is correlation of postural changes which are acquired like as you get older with POP. So women with pelvic organ prolapse have been shown to have increased rounding of their back, so increased thoracic kyphosis and decreased lumbar lordosis. So basically overall flattening of their spine, which theoretically I have mentioned, it creates a straight downward parachute movement. When we have the curves, I think it allows the pressure distribution in different directions, because the curve allows different pathways for the pressure to travel. And when those curves are gone, there's more likely for the pressure to travel downwards. This does not mean, and I would never say that to anyone, that their posture caused their prolapse. Please don't say that. Their posture did not cause their prolapse. Very often postural changes and prolapse happen together. Maybe posture reinforced some of it. Or there's an underlying change like bone loss and muscle loss that's causing both of those things at the same time. Okay. But the takeaway here is when we see that rounded, we kind of want to get them up and off the ground, make them taller. We want to talk about upper back rotation. We want to talk about upper back extension, talk about lats. Rib cage and pelvic floor. People have very restricted rib cage. This is a picture I found online, and this is a good one because you can see how arms are here and she wants to do, I'm assuming, an overhead movement. But look at her rib cage. Look at how much rib cage extension, how much lower back extension she has just to get her arms here. So we want to make sure that people's rib cage can stay in neutral position when they get their arms in that position or any position, because this is a very common position for lifters. This is a common position for people who are doing overhead lifts or holding the bar and they get pelvic floor symptoms. So now I think if you have a bar, maybe some extension is going to happen because it's behind you. But we do not want to see that much extension. And these people, these are back grippers. They will grip their back. They have an army posture. They cannot get a breath into their upper back. Their lats are super tight, okay? And they are very often creating an over engagement of pelvic floor, right? So their presentation is gripping here, upper abs, gripping in the upper back, gripping in the lats, and kind of lifting up from here. And we want to get them, and this is not necessarily postpartum, it's very common in lifters and athletes, and we want to get them up. We want to stretch these things out. We want to increase mobility here and let them sort of let that chest go down. And even if in a lift they have a demand to extend, I don't think I'm against that. I think if somebody chooses to extend because that's the movement they want to train, fine. But if your movement is happening with your arms and your intention is not to lift, then we should not be lifting. Hypermobility, we already talked about it. EDS, Marfans are more likely to develop prolapse. Let's make sure we know that hypermobility and bendy people, stretchy people, is not the same thing. If you can look up online a Baden scale, it's here. You'll get these slides too. And you can test people on that scale. They have to score a certain amount to be qualified. And even then, I think EDS diagnosis complex. But if they score more than 4 on a Baden scale, I think at that point we should probably start thinking about getting them screened for EDS by a doctor or by a PT. So they're more likely to have recurrent POP after surgeries. Okay, this is not the same as people who are bendy who do yoga. Okay, so people can have sort of good flexibility without any collagen mechanism dysfunction. And these are people who do not make good collagen, who do not make strong collagen. So they're chemically different, the collagen is. And hypermobility, where it's not EDS, does not increase the risk of POP. So we want to know that too. We don't want to create fear about being bendy. You're very bendy, your ligaments are going to get stretched. Diet and POP, we already talked about this. Constipation, bladder irritants, you can read about this. This is simple. All right. Exercise planning for a client of POP. So regardless if you are a PT or a trainer, your goal first is to get the people to understand that their pelvic floor can be over-engaged or overwhelmed. It can be both, right? It can be overwhelmed because it cannot create enough contraction. It can be over-engaged because it's creating too much contraction. We have to understand, get people to sort of understand this. Then we talk about their postural tendencies. We see how they stack up their ribcage and pelvis. Then we talk about what does the person need to do. And this is so missing in the medical model because a mom needs to pick up kids, right? I don't care if she can do a good squat or not. She's squatting every day, picking up kids. I gotta have her squat. There's just no way. Versus someone else who is a dancer and she needs to dance. Or someone who is in different stages of life and doesn't need to do either one of those. So we have to understand what they need to do and kind of prepare a program according to that. Because reality is that if they have prolapse symptoms after they run 2 miles, or if they have prolapse symptoms after they wear their baby for 45 minutes, a lot of exercises on a reformer on the mat or different places may not change the needle, may not move the needle as fast as we would like to. We have to get a little specific to what she wants to do, right? She wants to wear the baby. We have to get her weights in her arms. We have to do her farmer's carry or weighted vest. We have to talk about her stacking. We have to load the system in the way that she's going to load it. So when we have a prolapse person, especially as a PT, but also as a trainer, ask them, like, when do you feel these symptoms? When do they happen? And, a lot of times, like, yeah, it doesn't happen in the morning, but happens throughout the day randomly. And I will keep asking, I'll keep sort of finding out more about when oh, I felt it that night. What did you do before that? Oh, I went to pick up my baby from there, or I did laundry. If they did laundry and they felt symptoms, they need to be training squats and deadlifts. If they walked to the store and they felt the symptoms, they probably need to do more of weighted walks. Um, Not everyone's anatomy is same, not everyone's prolapse is same, not everyone's strength is same. So we have to see what they need to do when they have symptoms. Range of motion, we're going to talk about in a minute. What is their breath tendency? We talked about breath, like, do they want to breathe up here? They want to breathe up here. Can they expand here? All that stuff. Or are they very belly breathers? They think they're very good at it because they just blow up their belly. And then what's the bothersome movement and activity? Fun is necessary for function. I think trainers are great at it. Sometimes we as PTs are not so good at it. We gotta make this function fun for them, right? The exercises should look like what they want to do. They should eventually, few sessions we gotta we gotta drill down the basics, but then we should not be scared to have women move and do deadlifts and do squats and do other things, because reality is they're going to do that in life. You might as well do it with them and prepare them for it. Okay. Nobody's going to not squat in life. So, or if they are really not moving and just existing in the world like this, that's not helping them anyways. So like I said before, prolapse is not like, oh, it's grade 2 and tomorrow it's going to be grade 3. It doesn't work like that. So have a little bit more freedom to try things, harder things that you think they can do, they probably can. Okay, so this is a quick and dirty. If you are a PT, you're going to do a full body assessment, range of motion. But if you're a trainer, especially if you're a PT, you can do this, but especially if you're a trainer, these are the 5 movements. I find in my practice that if I get these 5 movements sort of in a good range of motion, I think I get a better expansion. Remember, distributing the force. So if these 5 movements are very limited, it's hard for me to get that expansion, that distribution of force. So I will screen these 5 movements, and if any of those 5 are very limited, I will give them exercises to improve one of those, whichever is limited. Okay, so this is quick and dirty. This is the dorsiflexion. My foot's about half the width length of my foot away. You can move further, and I'm bringing my knee on top of my second toe, and I want to see about 15 to 20 degrees of this movement, dorsiflexion. Dorsiflexion is important because people who don't have dorsiflexion enough bending in their will often turn their legs out in their squats and their lunges. They will turn their legs out like duck. They will turn more than they need to try to get lower in their squat. And that turn causes overactivity of the external rotators and sometimes increases tension in the pelvic floor. That turning out also takes away the ability for the adductors to engage, inner thigh to engage. And inner thigh is very important, gets weak in pregnancy, and also inner thigh helps. So I'm not against turning out, but if they're always turned out, they can't be neutral or close to neutral, like a little bit turned out, then we want to think about if they're limited in their dorsiflexion. Pelvic tilt. Oops. Is it so? Okay. Pelvic tilts. Against the wall. I want to see them have a good control of tilting forward of pelvis and tilting back of pelvis. Okay. Postpartum women struggle to get the posterior tilt, and postmenopausal women often struggle to get the anterior tilt. An easy exercise in lying down position is pelvic clock, where they can move the pelvis like a clock, forward, back, side to side. Okay. The next one is trunk rotation. I really want to see rotation. I'll often put like a pillow or something between their knees when I test this. I kind of want to see about 70 to 80 degrees of rotation. Rotation is very important. I'm not distinguishing between upper back rotation and lower back rotation here, but I'm looking at the person. I'm understanding where if they're really rotating all from the lower back. But somebody who gets close to 90 is going to rotate through the range reasonably so. And if this is limited, open books or thread the needle and all kinds of exercises, whichever profession and specialty you're in, you can give them those exercises to improve that rotation. Rotation really helps distribute that force. Shoulder abduction. And we talked about this. If people don't have this, then they get here and then to do this. And that really gets them out of the alignment for their rib cage. I missed one. Okay. Internal, external rotation. We want to see at least 10 to 15 degrees of internal rotation, about 45, 60 of external. Internal is generally the one that's limited. And internal rotation limitation is very common in postpartum women's, even in postmenopausal women. So a 90 degree position where they lift that back leg to sort of get some internal rotation is an easy one. Or if you have your both knees in and you can sort of do wind wipers to get the internal external rotation in. Okay. So how do you design a session? Now you know what she does, you know how it's going, you know what she needs to do. You're decided, okay, we're going to make a session for her. How do we design a session? Okay. I will generally warm up with 1 to 2 sets of just isolated pelvic floor breath contraction. So that deep core contraction that we talked about, where the whole pelvic floor lower abs kind of come up. If we have talked about long exhale, breathing in the back, that stuff, we reinforce that. And I want to practice that 1 to 2 sets, basically just to sort of prime their nervous system to prepare for what we're going to do. Then I'm gonna bring them a body scan. I'm gonna have them bring their awareness to the clitoral knot, especially if they have bladder prolapse. But even rectal prolapse happens in the vaginal canal. So the clitoral knot and lifting up really biases the contraction to the vaginal canal. So even rectal prolapse will help. Now, if the organ is coming out of the anal opening, that's a different thing. But all kinds of vaginal prolapse will generally benefit from clitoral knot. So I'll bring them a little awareness of that, right? I'll often have them put their hand here, feel that. And then I will usually get some high stake movements in first, okay? Fatigue is a real thing. When we are training women with prolapse, especially if you're a trainer, you need to know that their pelvic floor may get tired when their quads are not tired, right? Their pelvic floor may get tired when their glutes are not tired. So we have to take into account the fact that we want to get some movements, or especially high stake movements in before the fatigue sets in. Okay. Prioritize movements that are important to her function. If she's pushing a stroller, we got to do sled push. If she's wears the baby, we got to do weighted walk, right? If she picks up a baby all day, squats, deadlifts. Even if you are even if you are a Pilates trainer or yoga trainer, you gotta in your own way, in your own many ways that you can do, we gotta make sure that that some of their training looks like their life. Okay, because prolapse is very unique. It's not just about strength, right? You can have pelvic floor strength, you can have ab strength. It's a lot about the exact mechanics, right? In this position, in gravity, when she holds this, how do the ligaments sit? How does the fascia sit? How does the pelvic floor engage? What exactly happens? There's so many variables in prolapse symptoms that we can say that, oh, it's adductor weakness. If I strengthen adductors in a different way, it will help, right? We can sometimes say that for other runners, like if their calf is weak, we can strengthen their calf in many ways. We can do that pelvic floor too, but pelvic floor is so much more about position and gravity and pressure that if we get to a stage that's similar to her life, we're going to get better results. Okay. We already said prioritize movements that are symptomatic. So you're going to warm up, you're going to do a few sets with light, but we're going to start with the movements. Then we're going to get into the movements that are symptomatic before she gets tired. Alternate relationships with gravity. So when we stand up against gravity or we sit, organs fall, pelvic floor has to hold. We can really push this women to do more if we just go back and forth between gravity. So we do sitting movement here, right? Or we do standing deadlift. And then before she gets symptomatic, we go ahead, lie down and do some glute bridges. Okay. And you can do like really heavy glute bridges because glute bridges probably lying down isn't going to trigger her symptoms because gravity isn't playing on the pelvic organs in this. It's playing in other muscles, but not on pelvic organs. So instead of making everything easy, let's take the hard things, start with them, and then we take those other things and start playing with gravity. So sitting, standing, lying down, sitting, standing, lying down. Go back and forth between positions to see if she can tolerate more. A lot of times when we think, oh, we did squats and then we did deadlifts and now we're doing something else, and this something else is symptomatic. So we think, oh, this movement is bad because all the other movements were okay. We don't know that. That probably is fatigue. She's building up to this set now, right? So before assuming that this exercise, third, like say 40 pounds or deadlift is what's giving her symptom, let's see what has happened so far. We can change that. Can we put the 40 pounds of deadlift first, or can we go lie down, do some glute bridges, then come do sort of 40 pounds of deadlifts, or can we do some upper body movement sitting down and then go to 40 pounds of deadlift? So try to move session around because the reality is these women need strength. They need more muscle. They need more biceps. They need more tricep. They need more muscle bulk in their glutes. They need more actual muscle bulk. And the muscle bulk doesn't come until we do some resistance training. It doesn't come until we lift heavy things, or heavy for them anyways. So we have to push them to do heavy things, heavier than what they believe they should be doing. But we also can't make them symptomatic. So find ways to either play around with gravity, play around with movements, play around with other things I'm going to talk about to see if you can not regress their movement, not take away the weight. Do everything you can before you take away the weight or regress the activity or make it very easy because it's safe for her. Because our goal here is get them as much muscle as possible after we have talked about posture and breath and everything else. We have got the basics down, which is up till now. Now our goal is to get more muscle. Okay. For important movements, consider doing split sets. So let's say I had a woman who needed to go up the steps, like 2 flights of stairs with her baby, and she would feel it then. And she has to do 2 flights of stairs. So we were practicing stairs, we were doing step ups, and she could only do a few before feeling the symptoms. And she had about 24 steps. So we started doing 5 steps or 7 steps, then we go do something else, 5, 7 steps again, go do something else, 5 steps in again. And over a period of time, we were able to consolidate those. 5, 7 became 8, 10, became 10, 12. And by 10, 12 times, she could actually do 10, 12 steps. And that was a huge improvement for her. And that didn't take long, it took like 3 weeks. So know that she needs to do that movement. The way that her pelvic floor is challenged in a step up is very different than how it's challenged in a glute bridge or a deadlift. So if we just change the movement, it will be challenged in a different way. And then maybe we can come back to this movement and build more tolerance to it. Less is more. Sometimes we gotta do less exercises with a heavier resistance than do lots of exercises with minimum resistance for these women. Okay. Of course, we want them to work out longer. It's not like we make them feel like they can't do it. They should do cardio if they want to. But when it comes to strength training, we have to understand that let's do the movements that matter Let's do the resistance that matters, that changes their muscle bulk, and do less of it so that we see changes. I, as a PT, give them 4 exercises. All 4 of them are hard. I give them 2 in standing or sitting positions, 2 in lying down positions generally, and all of them are hard. None of them are easy. And I say 20 reps. I know you'll be sore, you'll be tired. And then most of the time, even if you feel symptoms after finishing this, as long as they go away when you lie down, we can talk about it next time. So uh, we are away from very long, very easy sessions. Okay. Or at least do the hard, important part in the beginning and then keep doing the easy part later. And if she gets tired, get symptomatic, stop. Should we cue pelvic floor during exercise? So, like I said, I prime their nervous system, I teach them, remind them. And once I have that in place, then I will ask them to practice that in life. I will say do 5 repetitions of that core contraction 5 times a day in 5 different positions. Okay. So sitting, standing, morning, evening, lying down, hands and knees, 5 different positions. You do 5 good contractions. Okay. All 5 times in a day. And they do this for 2, 3 weeks. And then hopefully their body got the idea. And now when they do an exercise, I will cue that breath, exhale and lift the pelvic floor as the weight goes up, exhale and lift the pelvic floor as the weight goes up, couple of reps, maybe 3 reps. And then I will say only cue breath. I will cue breath for a while because people tend to hold their breath to feel stronger. So I will keep cueing the breath if I have to. But ultimately, the goal is we get the coordination down, we get the alignment down. And now what we should do is just cue the breath, and the breath will bring along everything else. Okay. If the breath works, gravity automatically works, then pelvic floor should do what it was supposed to do. If it cannot do that, if she's symptomatic, we can do something else, all the other strategies I talked about. But I wouldn't have someone contract and pull the pelvic floor up for 2 sets of 10 deadlifts. I wouldn't do that. I would, at that, if I'm needing to do that for 2 full sets, I think they need to do a different activity. They need to do maybe alter the gravity a little bit. Maybe they need to do less weight. If I'm needing to cue her that much, then the activity is not automatic, and that's not an activity that's going to be productive in life. Okay, because one, thinking about all that contraction and creating that contraction really changes the form, right? It creates like lag in coordination. We want the core to be automatic. As soon as gravity comes, it works. As soon as exhale comes, it works. So we want to build the basics in few sessions to get them to the point of automatic. And then we want to keep pushing them at the edge of their tolerance, not too easy. But if they're needing that contraction again and again, we're going past that tolerance, maybe we come back a little bit. I generally ask for a 30 to 40% of your best contraction, even when I'm practicing. Know that timing is more important than power. I almost never say, pull the pelvic floor up and in as hard as you can. Okay. If they're exhaling and they're pulling up the pelvic floor with it, then as hard as you can will come from the activity when they're doing. So if she is doing and I give her 10 pounds, she's gonna contract a little bit. Like it's 10 pounds. We're sitting down. And if I cue her and she's lifting 40 pounds in a deadlift, her pelvic floor will contract a lot more. So our goal is not to determine how much the pelvic floor is going to contract. Our goal is to determine when it's going to contract, the timing with the exhale, and then it has the opportunity to contract. We are in the alignment and atmosphere. We're making it easy for it to contract. We can remind a few times, but then we gotta let the body decide how much contraction it wants to create. Okay. Because over contraction, and this is very prevalent in fitness world, unfortunately, is that when you lift 10 pounds, you tighten your muscles as much as you possible. When your people are doing deadlifts and they are lifting 20 pounds and they're contracting their abs or using weight belts, they're really contracting and they're only lifting 20 pounds. Why? We're creating unnecessary contraction, unnecessary pressure into the pelvic floor, which is not useful. It's not giving us anything. Okay, so timing is more important than power. What you should see is gentle, uniform flattening of lower belly. What you should not see is big suck in the belly, lower back flattening, butt gripping, upper back gripping, pelvis lifting. And then if somebody does say, I'm feeling worse, this is the like this definitely worse, my prolapse, I will sometimes say, go check in the restroom, right? You can you after you sit on the toilet, this is the vaginal opening, gently touch how much um prolapse or how much of substance do you feel, right? You feel a little bulge. Go after the session, check again how much bulge do you feel. It's very rare for me to see that their bulge is bigger. The pelvic floor is tired, the body is tired, the nervous system is giving them cue that we're tired. So we're tired and we can feel heaviness because we're tired. That doesn't mean we have more prolapse. And that's such an important distinction people miss. That heaviness does not mean more prolapse. Heaviness can mean same prolapse, more symptoms because your system is tired or your system is on a high guard. Check if you want to, but ideally I won't even have them check. I would just have them like, okay, happened one time, relax, go. And if it happens again and again with each movement, we got to reevaluate. But it happened once, there's no reason to freak out. Attention to task. This phrase came from a brilliant physio I took course with, Anthony Lowe, who said, how much engagement does a task really need, right? Are we always engaging too much to protect the pelvic floor? It's so common in women, like athletes or people who want to feel strong, that they will engage as much as possible because more is better. And now we really see not just in pelvic floor, but even in lower back and other areas of medicine that when we engage too much, we actually create too much pressure and unnecessary fatigue that doesn't get us good results. Okay, so don't engage to protect the pelvic floor, engage to respond. Pelvic floor is participating in the core system. Pelvic floor is not protecting the organs. Okay? Because if you use that, squeeze your pelvic floor so you protect your organs, people will keep squeezing the whole time. Okay? And that squeezing causes more symptoms. It's very common in pelvic floor conditions, but it's also common in lower back conditions that people are just engaging too much and that's hurting the back. Okay, so now we have this framework, which let's say that you're doing a movement, it's important to her, we need to do it, and it's causing symptoms. She's either feeling bulge, heaviness, she's feeling the leaking. What do you do? Do you modify? Do you regress? Those are two different things. Okay, don't interchange them. People often mean regression and use modification. Modification is doing something different. Regression is doing something easier. Difference. So if she is doing a plank and she has symptoms, now we tell her go do the plank on the wall. That's a regression, right? Regression is fine, but we have to know that I want to first modify. I don't want to make it easier for her because I want her to be stronger, right? So we can regress, fine, but can we modify first? So if she's in a plank and she has symptoms, I will often put a pillow or a yoga block between her knees, between her thighs, so she can squeeze and get a little bit of adductor action going on and see if that helps the her pelvic floor enough to hold the plank. without going into regression, right? So do we want to modify or do you want to regress? Is the pelvic floor over engaged or is it overwhelmed? Is over engaged? It's doing too much. We got to back off. Or it's overwhelmed, it's tired, it's fatigue, and we got to rest. So we want to, and over engaged, overwhelmed really comes from like, uh, it comes down to like you reading the person who is worried, stressed, and that often is overengaged, and like having symptoms with regular activities and having a lot of anxiety around form and posture and sort of like really honing in on different things, kind of obsessing about posture, obsessing about symptoms, obsessing about her grade, she probably is overengaged versus somebody who does movements and then she's like, yeah, I feel a little bit, or she doesn't even say anything but changes, like brings her legs a little bit together. So her sumo squat is getting narrower and narrower, or she's trying to pull her pelvis in and in. She's not saying anything, but that person is probably overwhelmed. Her pelvic floor is reacting and finding ways to do it, but she's changing her form. So, and again, you talking to your person will really help. So now this is happening. This is a situation. What do? We can change their alignment, right? Ribcage pelvis we talked about. We can do the ski jump. That term comes from one of my teachers, Julie Weeb. Great physio if you get to take her courses. But you know how if you've done ski jump, like you go forward and that forward, that slide forward from the ankle very often brings a good relationship of the diaphragm and the front of the pelvic floor. And it kind of, a lot of people are here when they're doing their double unders or they're jumping and they kind of driving into extension. The runners do that. So if we teach them, you're going to do a ski jump, it helps them get that alignment in. So you can change their alignment, talk about rib cage and pelvis. You can change where their weight is and their arches. Okay, we can give them the cue to squeeze the grapefruit, make the shoulders broad. So if we change their form, does the symptom get better? No. Can we change their breath? Can we exhale with exertion? Probably what we're doing, but that didn't work. Can we exhale before exertion? So exhale, hold, and then do the activity. Can we hiss through the movement? Okay. Or if she's very worried and it's a very low risk activity, can we actually inhale through the movement, teach her to relax? We can add a helper muscle, 3 helper muscles we have. We have the adductor, we can add a ball between her knees, we can add a band around her knees. So when we add these other things, or we can add a band between the forearms for a plank, very often that creates just enough activity in another body part that dissipates the pressure, okay? Then consider fatigue, right? Before we take that activity away, let's see if she can do a different activity in gravity eliminated plane, and then we can come back to this one, okay? We can change the relationship with gravity. So if upright movements are bothersome, we can bring her in the, so upright movements has more gravity. If we bring her here, less gravity, here, less gravity, and we'll see examples of these. And then finally, if the movement is very symptomatic, we want to talk about menses. Is she sleeping enough? Is she stressed? Where is she in her cycle? All those things are much more likely to be causing her symptom than her prolapse getting worse. Okay. All right. So we have a squat. Somebody is doing a squat. She has symptoms. Okay. Let's check. Is she doing a squat? When she's doing the squat, is she a back gripper? Does she grip her back, right? So the back grippers, when they do, they keep their chest up. And as they're doing their squats, they're getting into a lot of extension. I may tell her to squeeze a ball in front to get her to keep her from doing this. Okay, so I may say, keep this ball down on your sternum and squeeze it. And that may create a little bit less of that back gripping. Okay. Somebody who is collapsing, so somebody who's here and she actually keeps going into this, we can give her a cable to help her stay into slight extension, right? So we want this and this to line up. If this is happening, we give this help. If this is happening, we give this task. If somebody is doing squats, especially if they get low, the labia starts to open up, right? And they're very nervous because that makes them feel vulnerable. So I will sometimes say, as we go down into the squat, I will make it a little bit more uneven. And unevenness, when we go down, it's not a squat, it's kind of a lunge. It just creates just enough change in the sensation that they can tolerate it, okay? Of course, we can add a ball, we can add a helper muscle, we can add a ball between the knees, we can add band, we can put their heels up on something, we can keep their feet up on something without changing. We change her where her weight is. I give her helper muscles. I give her different breath strategies and see if we can keep what she's doing the same. Okay, so and changing relationship with gravity. So here's some examples that I use. One of them, I am lifting the heels. You can be on a board too. Ball between the knees, or same weight, but instead of going up and down, I gave her a ball and just had her do a wall squat. So hold that position, right? Without decreasing the weight. And then if somebody is really symptomatic with that, we can go into this position. And it's not a squat, but it is, I guess, similar to a squat. So it may help her nervous system get some sense. So when she goes back in this position, like hands and knees going back, her labia is also opening, right? If she's really symptomatic or nervous about labia opening, things feeling vulnerable, open, when we bring her in gravity eliminated positions and the labia opens, her nervous system gets a little bit more used to that sensation. Overhead press. So similar things will, when we have overhead press, and we'll have these slides. If I miss a point or two, you will have them. Make sure her rib cage is stacked. In overhead press, one thing I find it very easy is to do it with a ball between their knees, because overhead press often creates some degree of extension for a lot of people, especially if it's with a bar in the back. So I will give them, we can do them sitting, okay? But if they cannot do them or don't want to do it sitting, so a yoga block or something between their knees will just create enough adductor contraction that they might be able to manage that pressure, okay? The breath, exhale before exertion, exhale with exertion, all that. I'm going to talk about helper muscle in a minute. All the same things that we talk about. Here are the modifications. The first one, when I'm standing there, so because this movement causes this extension, which then sometimes creates a difficulty managing the pressure here, one thing that helps is if we just do it with one hand. So if we pull down with one hand and kind of create like a downward chest pull, then we are able to lift heavier with the other hand. So let's say she wanted to lift 40 pounds here. If I just hold this down and have her lift 20 here, and then hold this down, lift 20 here, it sometimes helps her lift what she would have wanted to lift, but with less, right? This is especially important. Moms need to lift their kids up like that. So if she's symptomatic lifting up like that, or she is symptomatic after she has done, so I'll have sometimes people say, I was getting my son in and out of the car, we were doing a lot of moving around, and then picking up the kid and putting them away, it's very often this, and she's symptomatic there. She needs to train how to get this body and how to lift weight above her head without the rib cage following her. And of course, that's all about upper body strength, but it's also about isolating how to get this down and still keep the body weight up, lift the weight up. And this is the other variation that you can use, which, oh, this is not a video. I thought this was a video. Okay, so when I'm lying down and you can use a heavier cable, I'm using a band, but they can lie down and do a overhead movement lying down where they will not be in gravity eliminated plane, gravity dependent plane. You can also do this on a ball. When you take away the gravity, try to add resistance. Make them do it really hard. So if they were lifting 20 pounds here, when she lies down and she does it with a cable, try to give her a lot more resistance. So now that the gravity is not in play, we really want to make those lats work. We really want to, really want to make those arms work. We really want to make sure that she is getting more muscle for the task. So when she goes back to gravity, these muscles are stronger to manage this, right? So when you're taking away the gravity and making things easier, let's say if she's standing up and she can't do a heel raise and you're bringing her in hands and knees position, increase the reps, make it harder, right? Make it harder in the easier plane. Sit up, crunch, boat pose. Um, this is a common one in like Pilates kinds of movements, uh, where people really, really engage their upper abs and their lower abs part is not really down. So if you have done all the foundational work that we've talked about, ideally this wouldn't happen. But let's say it does happen, then we can put a ball between their knees. We can also put a ball behind their back. I'm not showing this here, but my favorite one is to put a band around their ankles, their toes, and have them lift their toes towards their nose. Or if they're on a Pilates warmer, to put their toes underneath the bar and pull on the bar and hold that position. And that tends to create. In these kinds of movement, especially when we're kind of going straight into flexion, this straight into flexion, especially if you're not including any rotation, we're going straight to flexion, lifting the head and holding the head up there. Because the line of pressure is so directly into pelvic floor, these kinds of movements, especially if they're doing a lot of them, are probably one time that I actually will cue a pelvic floor contraction, because the line of pressure is so direct that pelvic floor, even if it's trying automatically, may be overwhelmed. So for sorry, we can engage for sit up kind of movement, and they're doing a straight sit up all the way up and they're feeling like they leak or pressure. I will say nod and pull the pelvic floor as you're coming up. So I'll actually cue pelvic floor contraction. So this is what we can do, right? We can engage. Right? Or we can do this one. Here I actually added some rotation. Like I said, rotation always helps because it distributes the pressure. Vagina is down here. When you're moving in flexion, when your plane of movement is limited to here, this, we tend to see more symptoms because vagina is right here. When we include some of this, we include some of this, we include different planes, the pressure distribution is a little bit easier. Okay. And here is the sit up. So this is the first sit up. You can see her bladder gets pushed down. This is my patient. And my second cue was exhale and nod your clitoris. And you can see that the arrow the pelvic floor comes up, and then the bladder comes up. But you can see how direct that relationship is. Like pelvic floors, abs are pushing straight into the bladder in this position. So this tends to be a position where you have to sort of cue, or it's useful to cue. If they're not symptomatic, don't cue. But if they're symptomatic, cueing that pelvic floor contraction will help. Okay. Downward dog, forward fold sometimes triggers symptoms. Um, One thing that's the easiest one in this one is to not is to tell them to turn their toes out. So have them sort of a slightly externally rotated, and that tends to get them enough support that they can tolerate it. Okay. You can tell them to tuck their tailbone, you can tell them to bend their elbows. Um, and then know that it's not forever. These modifications are not forever. In fact, I will highly recommend every few sessions you go back, take out some of those helper movements, take out some of those modifications, and see if you can do it harder. I tend to actually start every session with the actual movement, and then she's symptomatic, I add helper, I do the things that we talked about, and the next session I try to do the original movement again and add modification again if she's symptomatic. So I actually do it the other way around. But if you don't have time, because I see one patient at a time, you can definitely do the modification or the easier or the modified version with the helper muscles, but then see if you can every few sessions, see if you can take that away. One of the things I learned that Anthony Lowe said is stay very close to the fence because that's where the progress happens. So if you're not close to the fence, like if you're not close to their tolerance, they're not going to build muscle. And if they don't build muscle, they don't build more glutes, more hamstrings, the alignment of pelvis will not change. If they don't get more bulk in their pelvic floor, so doing easy stuff is more doing and less getting. Getting harder stuff is actually getting something. And my patients are surprised when their symptoms are better in 3, 4 weeks because they didn't expect that. They've been doing Kegels for months. But because I do hard stuff with them, we see progress a little bit quicker. So read there. That's why it's important. Doing hard stuff with them is risky. You have to understand everything. You have to know what you're doing. But stay close to the edge of tolerance without crossing it, and that will cause more muscle, more change. And again, after all the basics are done. Okay, so impact. Impact and POP. When we talk about impact, it is a different kind of contraction that we're talking about. Okay, so this is my biceps. This is my bicep. This is my biceps. And this is my biceps contracting concentrically, which means my bicep is shortening to lift the weight up. And this is my bicep contracting eccentrically, which means it's stretching, it's lengthening, but it's under control, which means it's working really, really hard. And if you lift heavy, you know this, that lifting a weight is absolutely easier than lowering that weight slowly. Okay, so lengthening a muscle under load is eccentric contraction, which is a harder contraction for all muscles, including pelvic floor. Okay, concentric and eccentric. So we have, when we jump or cough, the organs, when I jump, when I go up, my bladder goes up in the air, right? And as I come down, my bladder comes down and then it hits the pelvic floor. And what pelvic floor needs to do is it needs to give and then catch. It needs to eccentrically contract. It needs to lengthen. It needs to get bigger, but not in a relaxing way. It needs to get bigger in a controlled way. And it's same thing as my bicep lowering. My pelvic floor has to lower my bladder with control. So it's not like just free falling into the pelvic floor. It's catching the pelvic floor and lowering it slowly and then coming back to the resting phase. So this eccentric contraction of pelvic floor is a harder skill to learn, and it's a harder contraction to do, like all muscles. So it's easier to get up from a chair than to sit down into the chair very, 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 very slowly, because now our quads have to work eccentrically. Okay. Now, eccentric contraction of pelvic floor is not unique to impact, because every time I walk, I pick up my leg. When my leg goes back down, right? As soon as it hits the pelvic floor, bladder drops. Pelvic floor catches it. So we are eccentrically contracting the pelvic floor all the time. It's not new. But when we introduce the impact, the distance for which the bladder goes up and down increases, right? So if I'm just walking and my leg goes up and lands, my bladder goes up, bounces a little bit, comes down. But if I'm jumping, my bladder goes up more, drops down more, has more force from the gravity, and pelvic floor needs to catch more. Okay, so eccentric contraction, our body is doing all the time, but when we introduce impact, it needs to do more and for longer period of time. All right. So is there risk? Yes. Eccentric contraction is always harder. So when we introduce impact to people with pelvic organ prolapse, we have to make sure that we have done all the groundwork, right? We have done the basics, we have done a ton of strengthening, we have broken down these movements into different patterns. We'll talk about that. And then we're asking them to do impact. Like, we're not saying that you need to run, so let's practice running drills. We got to do all that other work. And after doing that other work, there is possibility for some women that they still cannot tolerate impact without symptoms. And we have other strategies for that, right? But the point I'm trying to make is eccentric contraction is harder, objectively harder. Okay, so that's an honest thing that we should know or talk to women about. So is there a risk? Yes, but walking is also a risk. As soon as you're upright, it is a risk. The probability of it should be low, and there's a lot we can do to manage and monitor these symptoms as we're walking, okay, as we are progressing. A study evaluating pelvic floor symptoms in those performing CrossFit identified that percentage of CrossFit participating experiencing POP where symptoms were consistent with other populations, which means CrossFit people who are doing so much more impact did not have more symptoms than POP patients who were not doing impact. Now, this study is a little bit dicey because CrossFit people are also strengthening a lot more, right? And we don't know what other group was doing. So we can't really say impact, but at least we can say that if you're strength training and then you're going to impact, which is most CrossFit people do that, they strength train and do impact, you're much more safer to do that. Okay, you still have to monitor symptoms. All right, is it desired? It will train the pelvic floor eccentric contraction more. For sure it will, okay? It's also not completely avoidable. We are all gonna step down from a big curve at some point. So it's not an activity we can completely avoid. Pelvic floor works eccentrically for longer duration. So what we need to do to prepare people, if they want to do impact activities, is to train eccentric control exercises. That's what we're gonna talk about. Are there benefits? Yes, for bone mass, for muscle mass, and for mental health. A lot of people really want to run, they really want to dance, they really want to do jumping jacks, like it's life. So in my practice, I will ask them, what do you want to do? If you didn't have any prolapse, what is it that you would be doing? And they say, I would be running. It's like, okay, we're going to do a lot of basic work, we're going to a lot of strength training. You have to get to running, but I'm going to do everything I can to get you to running. So our ultimate goal is to help make client an informed choice. So there some things to consider when we're talking about impact is, what is the grade of prolapse? right? So if we are talking about a grade 3 or 4, we probably should be considering a pessary right away because, like we talked about, 2 is more manageable with the contraction and management strategies. 3 and 4 probably is not. So if it's a grade 3 or 4, we want to talk about a pessary. What type of prolapse they have, how psychologically distressed or worried is this woman, right? We talked about all of these. How worried will she get if when she's running? Does her life involve impact, running around with kids? Does her mental health improve with impact? CrossFitters, dancers, athletes, runners, they really want to do those things because they make them happy. And I don't think there's any use of life if you can't do things that make you happy. So when we are implementing impact, we want to consider pessary. Okay. Um, they should have had at least 1 pelvic floor visits. Okay. And at this point, when they're introducing impact, we should have regular check-ins with pelvic floor PT. I find that strength of 3 or more is important. So they should be able to, if you're a PT, a perfect score, I want to see 3+ strength at that point. If PT is not accessible, they can do a self-exam and perineal exam and put a finger in to test how the squeeze is, or virtually meet with the pelvic floor PT to do that. Consider introducing during estrogen-rich stage of the cycle, especially if the person is symptomatic with the cycle, right? You're gonna do eccentric drills. We're gonna teach people to slowly lower their body weight in the phases of movement where the eccentric activity of the pelvic floor happens. We'll talk about that. Softer landings. So let's say we are working on jumping jacks, right? So what we want to say is, how light can you be on your feet when you jump instead of making very heavy noise on the feet? So how light can you be? And softer landings will generally decrease the impact on pelvic floor. Okay. Hip flexion may increase the likelihood that the pubic bone can support the pelvic organs. And this is a common modification I make for people who are doing jumping jacks, right? And they're doing jumping jacks and they're symptomatic. I will say, okay, we're going to do squat jacks. So get into a hip hinge and squat. And now go ahead, do the same movement, very light on your feet. And this hip hinge tends to catch the bladder behind the pubic bone. It also helps bring that relationship of the diaphragm and pelvic floor. So somebody doing jumping jacks here is much more likely to get here, right? Somebody doing jumping jacks here now has more quads, more knee bend to take the impact, right? They're lighter on their feet, so they can use more legs. And also, they have better relationship of their diaphragm and pelvic floor, so pelvic floor can contract better. My cue generally is exhale every time your feet hit the floor. So it'll be like, okay, and of course we'll be doing it with shoes. So, and when I'm training this movement, I will say, okay, so we're gonna go down slowly, slowly, and come up. Inhale, slowly, slowly. So I'm gonna really, if you do training, you probably play around with tempo. So I'm gonna reduce the tempo. I'm gonna increase the count for the eccentric control of that movement. So the part of the movement where you're supposed to inhale, the pelvic floor is supposed to lengthen. I'm gonna increase that tempo. So you're gonna go down for a count of 4 and come up for a count of 1. So you're gonna go 1, 2, 3, 4. Right? And at this point, 1, 2, 3, 4, I'm inhaling. So when I inhale, the pelvic floor lengthens, and then I exhale, come up. Inhale, pelvic floor lengthens, exhale, come up. So when I'm getting people from simple strength training to an actual impact movement, I will increase that simple strength training's eccentric phase. Okay, so I'm going to say, your movement's going to look like this. So what we're going to do is go down slowly, go down slowly, go down slowly. So I'm going to train the eccentric phase and keep pushing that. If she gets symptomatic, you're gonna scale back, but keep pushing the eccentric phase to train the eccentric contraction of the pelvic floor. Okay. Really try avoid bracing and holding. Holding breath, holding pelvic floor really doesn't help. All right. Impact drills. Okay, so we have that forward lean and we are practicing marches. Sometimes my cue is to push into the table, basically creating a little bit of expansion in the back part of the lungs, right? Back part of, we talked about that. And serratus interior starts working, which gets us to a better breath in the back. But that forward lean position with the hand takes some of the weight of our body away and also helps us bring that pelvic floor, the diaphragm over the pelvic floor. I would do these impact drills after I have worked on the eccentric control exercises. So we started with the basics, right? Breath, posture, all that. We went to strength training. Then we went to eccentric control training. And then we went to impact drills. So we have that progression. We're bringing the system through that. And that doesn't have to take months, but we're bringing the system through that to make sure that pelvic floor can work automatically. Okay. And every time I'm exhaling, and that's a nice, easy way to challenge the pelvic floor in eccentric contraction quickly. And I'm never cueing any pelvic floor contraction at all. Okay. And then we can alter the relationship of gravity. I'm using a foam pad basically to increase the give a little bit and increase the challenge. You don't have to. Plank jacks, right? So if jumping jacks are symptomatic, which they are for a lot of people, we can go and do a plank jack. So we're going down. I can't go down. You'll be able to see me. But if you're on the high surface, if you did a plank jack here, if you did a jumping jack here, you're much less likely to be symptomatic because the pubic bone will catch the bladder. Also, you're not quite fighting the gravity as much. Okay. A lot of these movements, like the squat jack that I told you and plank jack, these movements are harder than a real jumping jack, right? In jumping jack, you were just moving the arms and legs. So the other movements are actually harder because now you're bending the knee. So you're working harder in your quads, you're working harder in your arms. So they should give you more of a workout. But then you slowly come away from that and see if you can actually progress towards vertical alignment. In the plank position, we can also do mountain climbers, right? Tramp Pilates jump is one of my favorite ones. I do that a lot with my clients to basically they are neutral, they're horizontal, and now they can practice some of that jumping without the effect of gravity. Ideally, we would have some degree, some way of like slowly progressing it to that position. Okay. All right. Running. So running is impact, obviously, but running is more than impact. Okay. Uh, Running is impact, but running is more than impact. So we are talking about this because it's specific. One, it's very common for people to want to run. It's also very common for people to have symptoms with running. So, because a lot going goes into running mechanics, and it's an activity that people do for longer periods of time, we should probably prepare them more. Okay. One thing I want to say before I get into this is if somebody gets symptomatic at 2 miles run or 3 miles run, try to have them come in at 2 miles and 3 miles to see what they look like in terms of their posture and everything, and also their pelvic floor. So if their symptom really kicks in after 2 miles, you have to evaluate them at 2 miles. All right. So in running, what we typically see is again a lot of generalization here, but this is what I see in my clinical experience. I'm trying to give you what I see. This is not necessarily research. Some of this is research, but not necessarily all of it. I'm trying to give you just clinical information that I have found helpful. Um, Typically, clients have loss of trunk rotation. So they have a lot of this shifting going on in their body when they run versus a pure rotation. Okay. So one of the things that we can practice is to, you have done all the drills for the basics, getting their rotation, all the other things we talked about, but to put them in split stance, one leg in the front, one in the back, and just have them work on that rotation, really have them drill down how to get the rotation. I'll often have them take like two bands and pull forward like this and move forward, front and back, and do that for some time. And now you can add to help, and then of course you'll do it on the other leg as a drill to reinforce rotation in their form. Falling forward in a ski jump. So I'll often say to my runners, think of running as just falling forward. You started fall forward and then you kept falling, you kept going. A lot of runners run like this, chest up, core tight, and that drives the pressure down. So teaching them to sort of lean from the ankle, like you're going to do a ski jump, lean from the ankle, and then get this nice alignment feeling of it, and then you're just gonna keep falling forward in that position, and that's a sort of a good running form if you can maintain it with breath. And very often at two, they'll start here, and 2 miles when they have the symptoms, I'll find them here. I'll find them running like this, right? So one, we can correct that, but also maybe that's the point that their body is tired or their cardiovascular system is struggling and they have to do this. Increase cadence, slowly increase it by 5%. So basically, people, especially postpartum women, are sometimes running too slow. And slow running means the ground reaction force is more. So you spend more impact, you spend more time there. Increasing cadence and increase it slowly makes the time, the impact is actually less. Okay. So short, quick steps. We'll often say run light, quick, and stacked. Light, like you're kind of shuffling, like you're very light on your feet, and smaller stride. Do not overstride. Every time you get too far out of your, uh, what is this? Center of gravity, you have more impact. You travel more down, right? Your eccentric load and demand is more. So do not overstride, do not take bigger than you can manage steps, and run light, quick. So sometimes the cue is actually to run a little bit faster. Okay. Smaller steps, faster. So we're not really necessarily increasing the distance here. We're just going a little bit faster. Let the belly go. Do not pull the belly in. That's a difficult one for people to sort of really hone in on. Lateral shuffle, I will often see, and this happens in postpartum runners a lot, but it also happens in other, is that as they get farther and farther into the run, they really become narrower. Like they run with their legs together. or sometimes they even run with scissoring legs, right? So of course there can be weakness and other things we can talk about. But in terms of pelvic organ prolapse, sometimes they just don't like the feeling of openness, right? And they can't run with their legs together. They can't run with scissored legs. Okay, so sometimes I'll have them practice a little lateral shuffle, because when you do that lateral shuffle, the challenge, the eccentric challenge for the pelvic floor is different than when you do this. Okay, but when you actually when you're actually doing the running, it's not just this activity, right? It's not straight. There's rotation involved, there's lateral movement involved in complex running. So if they become very, very narrow in their stance, one, it's not good form, but also they are really challenging pelvic floor in a very narrow plane. So getting that lateral shuffle side to side kind of challenges them to get some eccentric control in these positions, in the lateral direction, because the lateral fibers of pubococcygeus has to fire more than the medial fibers. So I'll often get them to do this and get them a little more comfortable with that openness that they feel in their vaginas, as long as it's not truly symptomatic. You'll see a lot of people get nervous as soon as their labia starts to open, even if they don't really feel any heaviness. And that, I think, is like nervousness. And that nervousness keeps them stuck in that pattern of squeezing. So sometimes I'll be like, okay, I know your labia feels open, things feel like open, but are they open or are they falling? They're falling, we will think about it. But they're open, that could be okay. And someone's like, oh no, I don't know, this doesn't feel right. So we'll do an exam, or you, as a trainer, you can tell the woman, go check in the toilet. Is it really falling? Or you're just so used to keeping things together because you want to suck everything in, right? Okay. Start with supportive shoes, arches, our arches, our knees, right? They're both ways to take some of that impact. Our arches, our calf, arch and calf both, right? So dorsiflexion, when we land on our arches, when we dorsiflex, and when we bend our knees, take some of that impact away from what travels to the pelvic floor. So if we use all of those things efficiently, we will have less coming here. And shoes can add that. So I'll have supportive shoes, especially when they're starting it. Uphill running. Uphill running is hard, obviously, but I feel that for short distances of uphill running really gets postpartum women out of this, right? It's very hard for them to like feel this is not forward until I get them uphill running or slight incline on the treadmill and ask them to walk fast. And then they feel, oh yeah, this helps me engage. Like if I create a little incline on the trampoline treadmill and ask her to walk fast, like not run, but fast walk. And after walking a little bit, I'll be like, where do you feel it? How do you feel? She's like, yeah, I feel it here. I feel it here. And that might help them feel it. So when they run, they can feel like, oh yeah, that's where I need to be. Because run for a lot of people has become this. Okay. Downhill walking, so uphill running or uphill fast walking. Uphill is the place to train them to feel their lower abs and pelvic floor work because of the lean position. And downhill walking will train the eccentric control. Now, downhill, of course, can do this. So we have to cue them to keep their chest controlled. But when we are walking downhill, we're fighting more gravity because we're traveling further with each step. So it will demand more from the eccentric control. So if you're really in further stages of training somebody to run longer distances, downhill walking can help eccentric control as long as it's not symptomatic. Okay. All right. The running readiness test. This is an online resource that everyone should use. It has a basic exam that you do. I don't think it's enough to get pelvic floor people, prolapse people to run or leak people who have leaking, but people who have no symptoms at all should take this test, or you as a trainer or PT should administer this test to make sure they are okay with this. And generally it's not recommended to run before 12 weeks. So you should be start moving, exercising, strength training, then do the run readiness test, and don't think about running before 12 weeks postpartum. Right? This is an example of running. I'm going to first train the range. I'm going to make sure that she has full range of this movement that we need to do. Then we're going to increase the eccentric phase, right? So I said this is what we need to do. So I'm exaggerating. This is running. So I'm exaggerating the range of motion. I'm asking her to do that. Then I'm going to say, okay, now we're good with range. I didn't show that here, but I'm going to add weights. So I'm going to add weights, or I can add a weighted vest, or I'm going to say, okay, keep doing that same movement on both sides. And then when I'm ready to add, uh, after resistance, I'm ready to add some eccentric control. So I'm going to say, okay, so when you go down, slow, come push up. Go down, slow, come push up, right? And then I'm going to add impact. So I'll show you the example. Phase 1, 2, 3, I just kind of made up, but you can start wherever the person is. So going down slowly, coming up fast. Then I progress to single leg, and here I'm adding a little bit of impact. And when my toe leaves the ground, that's my general cue. How to calm down symptoms. You will sometimes, your clients will sometimes have increased symptoms. We talked about how to calm down that anxiety about prolapse being worse and everything else. But if they are symptomatic, we need to calm their symptoms down. These are the two positions that generally work. And the logic here is gravity pulls the organs back down, pelvic floor is not taking any weight, and they can get in these positions and breathe. Very often, I will do a hard movement, and if she's feeling scared or she's having symptoms, I'll say, okay, go lie down, put under the pillow under your pelvis, and feet up on the wall or couch. And that will, and stay there, breathe, relax your pelvis for like 5 minutes, and the symptoms will settle down. Okay. The second position is more important for people who really feel like who you really feel like are having hard time relaxing their pelvic floor, like they're clenching all the time. That sort of modified child's pose creates a little stretch in the glutes, a little openness in the back side of the body where they're probably holding a lot of tension. Okay. Sometimes, if I know the person is not tight, if I know person is like over engaging, over aware, then I will just have them there, maybe put a heating pad on their back or my hand on their back, like, okay, breathe into my hand, sigh, and sort of calm their nervous system down. And if a person who truly is like, I know they're not nervous, they're over fatigued, they're tired, then I may say, okay, lie down, and then do some submaximal, like gentle pelvic floor contractions to sort of give their nervous system a little support, a sense of support. Okay, now, this is for people who are lifting heavy. Now, when we approach high effort, we're talking about weightlifting, powerlifting, we're talking about really heavy lifts. When we get to that part of the effort, we have to know that there's okay. When approaching high effort, breath hold is usually required. Okay. So that presents a possibility that there will be increased intra-abdominal pressure. Remember in the beginning, I said, when you lift really heavy, you're gonna have to breathe in, hold that breath, squeeze your abs. And ideally, your pelvic floor will squeeze with it, okay? But there's a possibility that it cannot, and it's going to feel the pressure. So when we lift really heavy, we have to do that. We just have to make sure, one, that they're doing what we call a Valsalva. They're doing a proper brace. They're not doing a straining. And the straining and Valsalva has been used back and forth in research, which is very confusing because they're different things. Straining is, so when we breathe into the belly, right, and the belly is big, we hold the breath, we squeeze the abs, and we squeeze the pelvic floor, right? So everything is getting squeezed. That's Valsalva. But because we're holding the breath and we're putting weight on top, there is a possibility that the contraction of the pelvic floor isn't going to be enough to manage this pressure. But that's very different than taking a big breath in, engaging, holding that breath, and pushing down into the pelvic floor, not even attempting a pelvic floor contraction. Okay, so let's make sure that our athletes are at least doing the Valsalva properly. They're not doing straining, because a lot of people out in the fitness world are actually doing straining. And the thing is that if you have never been pregnant and you don't have any connective tissue disorder, you breathe in, hold your breath, and bear down into the pelvic floor, you still might not leak. So sometimes people are straining instead of doing Valsalva when they're lifting very heavy and they're not feeling anything in their pelvis or leaking or doing, like, they're fine, they're feeling fine, even though they're straining, because their fascia and pelvic floor is not weak. Their organs are not, like, they've never been pregnant. So we are straining into the pelvic floor. We may not feel any symptoms. And I see this a lot in women who are lifting, and they come to me in the clinic and I'll ask them, how do you lift? Whether they're pregnant or postpartum, they have history of powerlifting or heavy lifting, not powerlifting. And they will show me how they contract their pelvic floor. They take a big breath in and they squeeze their abs, and pelvic floor does nothing. All the pressure goes down, pelvic floor bulges, they're not bearing down, but pelvic floor is not doing anything, no contraction whatsoever. Okay, so let's make sure that our athletes are doing Valsalva properly. Now, know that even if they did Valsalva, it may not be enough, and we may need to modify or talk about symptoms and pessary and all that other stuff. But at least make sure they do Valsalva properly. Okay, so we are breathing in. And as after we breathe in, we expand our belly or expand our trunk, breathe in. Then we're going to hold our breath, okay? And then we're going to do what we might be doing. Pretend that you're about to sneeze really hard. So breathe in. My mouth is closed, so I'm not going to sneeze, but pretend that you're sneezing. And when that happens, you should feel a pelvic floor contraction and the ab contraction, okay? So big breath in. And you may feel that the abs get hard, but if you're doing it yourself, you should feel the pelvic floor contract. If you don't feel that in your person, in your client or patient, then you have to go back to the basics of the deep core contraction and teach them how to coordinate that contraction of bringing the pelvic floor along. Okay, so this is contracting, this is diaphragm is coming down, abs are contracting, pelvic floor is contracting, everything is contracting, and they still feel symptoms. That's a very different thing than these both are contracting and just pushing down into the pelvic floor. That's straining. Straining is what we do when we poop. Valsalva is what we do when we lift. Straining and Valsalva are not the same things. Okay, so if you're a PT, do an internal exam, preferably in standing, and ask them to do what they do to prepare for a heavy lift. Okay? If you are a trainer, have the person put their hands in their vagina in standing and have them do what they do when they lift very heavy. If If they don't feel any pull, if they don't feel any contraction, then they're straining. You don't even have to feel bearing down. You should feel contraction. Feel as soon as the abs go, the pelvic floor should go with it. If it doesn't go at all, then when we load that system, it's going to be straining. Okay. Last one. What if symptoms with exercises are okay? Right? I have come across this question many times in my career where, we tell women don't do this, don't do that, and they get disheartened and they just quit PT, right? They say, yeah, I'm just not going to do this. I'm going to run, and when the organ falls out, I'm going to get a surgery. So when we stop people from doing what they want to do, we risk them not doing what they can do to get better. Or when we give them ultimatums, you're never going to run, never going to lift, you're never going to do this or that, we take away the hope that they can build to that. I have found I will say yes to everything. They want to do this. Okay, yes, I'm going to work towards it. And as we work towards that, sometimes if it truly is not appropriate for them, the woman will come to that realization herself and will tell me that, maybe that's not the ideal. I'm enjoying this lifting so much. So before we say no, we have to get into the habit of saying yes, right? Yes, we're going to try to do this. We're going to absolutely try to do this. Um, I also find that it's not always, now this, take this with, caution, that it's not always bad to have symptoms. Every time you raise the resistance a little bit, the nervous system has a little problem, their muscles are a little tired. So you may get a little symptoms. Yes, pay attention to it, but it shouldn't be like, oh my God, symptoms run away. When I increase, I'm a little more comfortable doing it, because when I increase resistance and they have symptoms, I can do an exam, be like, no, everything is fine, you're tired. Um, but when you increase resistance as a trainer and they have symptoms, you may not be so sure. So you can teach them uh, how to feel it, but also know that it's okay sometimes for the symptoms to worsen when you increase the level. Like our quads get so tired, they burn. We don't even consider a workout a good workout until our muscles are sore, which I don't agree with, but that's what happens. Know that that tired, fatigue, sore feeling in pelvic floor in organ prolapse can be the heaviness. So we don't want to keep pushing it. We don't want to chase it, but it's not this big bad thing that happened. And also, it's if symptomatic activity is completely avoidable, like my patient who had to walk up the steps, like they're going to do it anyways, then you might as well train and do it with symptoms and at least reinforce. Like if she's going to do a step, 24 steps anyways with a weight, then I might as well train her for 24 steps with symptoms and make her quads stronger and make her abs stronger, make her glutes stronger for those 24 steps, even if she's symptomatic, because she's going to do this anyways, right? So client autonomy is very important, and I feel like we really need to honor that and understand that prolapse isn't this like end of life diagnosis, everything's going to fall apart, organs just falling out, everything's just going to go downhill. It can stay stable, it can improve. And if we give that hope to patients, at least my patients, they see improvement. All right, that is it. We made good time. All right. I'm going to send you a questionnaire with review, a form. So please fill it out. It really helps me. Last time I had feedback to take out some of the introduction slides and spend more time in exercises. So I did that this time. So whatever, feedback you give me, I will apply it to next year. And if it's useful to you and you give me a testimonial, that really helps me. So thank you so much. These are your references, and let's go and do some questions. All right, we're gonna stop sharing. All right. I'm going to go through the chat first, and then you can ask. All right. I think you can find some evidence about foot pelvic floor pelvic connection EBFA barefoot courses. What is EBFA?
It's evidence-based fitness academy.
Oh, I'll look that up. Thank you.
You're welcome.
What are your thoughts on exercises that invert the body? I see a lot of fitness professionals doing a bridge with heels elevated or bridges elevating the pelvis on a foam roller, for example. They can be good modifications to take the gravity away, right? I don't think it's necessarily a thing that we have to do unless it leads to a meaningful movement, right? You take away gravity, the symptoms go away. That doesn't really change anything. The gravity is going to come back and the symptoms going to come back. So if you're doing that modification, going against gravity in a meaningful way to progress towards an activity in gravity or in life, that's useful, right? But just to take away gravity and the organs go back, they're not going to stay there. I don't think that's going to happen. So, inversion just for the sake of inversion, I don't think is helpful. I don't think it has necessarily important. Nuance between modification and regression so helpful. Thank you. Of course. Um, Pallavis. The way I understand Valsalva is cranially directed pressure and straining bearing down is caudally directed pressure. Is that how you see it too? Um, Valsalva is a bilateral pressure, down and up. Okay. So when you are taking a breath in and holding that breath, the diaphragm is going down. So that breath retention is a downward pressure. There's no two ways about it. When you're gonna lift very heavy, you're going to create downward pressure. The thing is that it's two ways. So pelvic floor comes up and then hopefully they balance each other out. Um, so I would say Valsalva is a bilateral pressure versus uh, what is that other? Straining is a unilateral downward pressure. If somebody is not leaking in a straining movement, right? So if somebody is lifting very heavy and they're straining, what they're really doing, the reason they're not leaking is because their pelvic fascia is holding on. Their passive structures are holding on and taking that load. And over a period of time, there's a risk that that passive structure will keep getting weaker and weaker. And we see that much more clearly in postpartum because that passive structure is already weak, already stretched out. If somebody's constipation is menstruation related, then how do you go about it? So this is like there's a lot of things you can do, right? We are talking about hormonal changes. So they probably have to start tracking what they're eating and how they're feeling, right? Because as the estrogen goes down and progesterone increases, our rectum is a little bit relaxed, our intestines are a little bit relaxed. So things are kind of slow moving. Progesterone slows everything down. Now, that may not be the case for everyone, but for people who are symptomatic, specifically because of menstruation, are symptomatic because their gut is slower. So let's give it less work, right? Let's not give it high sodium food. Let's not give it very many insoluble fibers. Let's try to give it easier fibers to direct. Maybe give it a little bit psyllium husk, give it more water, give it more gentle movement, abdominal massage. You can look at I Love You massage online. So you know, understand how hormonal change is affecting your GI system and manage it. Now, in pregnancy, when sometimes, or even in menstruation, in like endometriosis or that kind of thing, where hormonal changes are so severe, I will sometimes say or talk to the practitioner to see if the woman can take something for a few days to manage constipation. If it's like I would do it with diet. I would do it following all the other thing. I would happily do it with a dietitian or a nutritionist, and doing some abdominal massage. When all other fails, we can go to some medication, Miralax or something towards for those 3 days. Okay. Does that help, Vaishnavi?
Yes, yes, it does.
Great.
Thank you.
All right. So that is all the question in the chat. So you can unmute yourself, ask a question. I'm here.
Can I ask a question? Hi. Can you clarify a little bit more about when you would recommend cueing core engagement and pelvic floor engagement with different exercises? I noticed you mentioned like running, for example, we want to encourage clients to relax their core. And eventually with a Valsalva maneuver, we want to encourage them to engage pelvic floor. But when we're doing regular strength training, it seems like we want to avoid cueing engagement of the pelvic floor. Is that correct?
Yeah. So yes, good question. So basically, one time I find pelvic floor engagement is I cue it is when they're doing a lot of direct flexion. So they're doing sit-ups, crunches, or modifications of that very direct line of pressure into the bladder. So if they're not symptomatic, I may not, but if they're symptomatic, or if I see with the ultrasound that there is descent and not enough pressure, then I will cue, nod, and pull with the clitoris. And I'm with running, we don't want to. With strength training, we don't want to. Even with Valsalva, I actually don't want to cue the pelvic floor contraction. I want to see it happen. So we see that after I train the deep core coordination, right? And I train good exhalation and strong exhalation. And they practice that. Then when I ask them to take a breath in, hold their breath, and pretend like they're going to sneeze, I should see that because that's normal. So I will not cue it because, especially because in heavy lifts, I don't want to cue people too much because that's a very heavy lift and their system needs to do what feels the safest. So if they can't get that, if after all that practice, if they cannot get the Valsalva correct, then I would practice the Valsalva with them, like contraction, and then pretend like you're sneezing, contraction, pretend like you're sneezing. But in real lift, I would still not cue them. I feel that actual lifting, especially when they are lifting heavy, we gotta let their system do what it needs to do to not hurt their back or not hurt their arms. And too many cues disrupts that coordination. So we want to make this active. We want to make it anticipatory core engagement before we get to the phase of lifting heavy, if that makes sense.
Okay, yeah, I think so. So cue it when you're practicing outside of the strength training, and then when you're actually doing the strength moves, allow their nervous system and their body to react in the way that's natural.
And before you do that, like you practice in all these positions, have them stand and do an exam. If you do pelvic floor exam, do an exam and say, pretend you're about to lift and do what you would do to prepare for that lift. Don't without any cueing. And or
Mhm.
say, breathe in and pretend you're about to sneeze. And you should feel that.
Awesome. Thank you.
Anyone else? All right, all good? Okay, then I am going to turn this off. And this obviously is recorded. I'm going to edit and process this recording. It probably will go out in like 48 hours or so. Okay. I'm going to send out an email later because I know there were a lot of people from Europe and Australia who couldn't attend. I'm going to send out an email to see if there's interest in doing like a follow-up question session. Because I know a lot of people couldn't attend. Or you can send me questions, and I'll just record and answer the question and then send it to all of you, like in a common email. Okay. All right. Thank you for coming. Have a nice day.
Thank you.